Good morning and good afternoon for those of you who are in a different time zone as I am. I am Dr. Lyudmila Bazhenova. I'm a thoracic medical oncologist from University of California, San Diego, and I will be chairing the webinar today. So today we're going to be learning about targeted therapy in lung cancer. We have a fairly robust lineup of speakers. The webinar is gonna have a format where our professors and speakers will present. The question and answer session will be pushed to after the presentations have concluded. And there is a way for you as participants to ask questions. Before we begin, I'd like to thank sponsors that made that webinar possible. And this is Genentech, Bristol Myers Squibb, Lilly, Takeda, Janssen, Daiichi Sankyo, Foundation Medicine, and Bayer. To start, it is my distinct pleasure to introduce Dr. Joshua Royce, who is an assistant professor of medicine from Georgetown Lombardi Comprehensive Cancer Center, and he will be discussing biomarker testing fundamentals. Welcome,
Thank,
Josh.
thank you, Dr. Bashanova. It's great to be here. And yes, good morning, good afternoon, good evening, and good night. To quote the Truman Show here. Excited to share this with you guys and to kick things off with a discussion of biomarker testing. So I believe my slides are shared, so I should be good to go. So again, I'm Dr. Joshua Royce, thoracic medical oncologist at Georgetown University. And today we're going to be discussing first, to kick things off, biomarker testing 101. Find the right therapy, not the fastest therapy. These are my disclosures. So let's start with a question, true or false? Molecular testing plays a critical role in all stages of non-small cell lung cancer, including early stage non-small cell lung cancer treated with surgery, locally advanced non-small cell lung cancer treated with definitive curative chemoradiotherapy, and advanced non-small cell lung cancer treated primarily with systemic therapies. And the answer to that is true. We are now fortunate that we've entered an era where our more advanced treatments, immunotherapies, and targeted therapies have trickled down to the locally advanced and localized setting to try to enhance cure rates for our patients. So, what does that mean? Well, that means in the setting of surgery, in many cases, we recommend potentially chemotherapy, targeted therapies, and/or immunotherapy. That is also the case in locally advanced unresectable disease, where osimertinib and durvalumab are approved for appropriate patients, EGFR mutated and no driver mutations, respectively. And then obviously in advanced disease, where we have a whole host of available treatments with targeted therapies, chemotherapy, and immunotherapy. So again, kind of to echo that, there really is an ever expanding, non-overlapping palette of treatment options available for our patients, kind of like the painted rocks here. You know, so many distinct treatments we have available to us, from targeted therapies to immunotherapies to novel antibody drug conjugates. Here is a list here that's ever expanding. It's quite possible there's something yet to be added to this list that I just created just a couple months ago. But the thing is, you need biomarker testing to know which treatments are most appropriate. Without that, it is like you are driving blind and in the dark. And we really can't have that in today's era of treatment. So, what are we looking for in the cancer when we talk about biomarker testing? Well, there's a couple different alterations that we are looking for. The first are point mutations and insertions and deletions. What is this? These are single alterations in the genes that encode certain proteins. So these are mutations where one alteration to another amino acid or protein. They are insertions or deletions in the DNA. All these are things that alter the conformation of the protein that alters the signaling and causes unchecked growth. At its core, cancer is that, it's unchecked growth. And so examples of these types of alterations are EGFR, exon 19 deletion, L858R mutation are classical EGFR alterations, as well as exon 20 insertion, MET skipping, KRAS, BRAF, HER2, just to name a few. Then there are gene fusions. This is when one gene combines with another gene to cause unchecked growth. So perhaps the signal, the protein that itself is kind of causing the growth, that part is essentially normal, but then it fuses with an upstream signal that is always on. So again, causing this protein to signal abnormally, causing unchecked growth. And examples of that are ALK, ROS1, RET, NTRK, NRG1. Then there's gene amplification. In this setting, the gene itself is normal. The protein is normal, but it's more of it. It's more genes. So more copies of genes causes more protein, causes more growth signal. This is oftentimes the mechanism of resistance to some of our targeted therapies, such as EGFR, where we can see MET amplification, MET amplification, or HER2 amplification. And then another example of alterations that we see are just increased amounts of the protein on the cell surface of the cancer. Now, sometimes this contributes to unchecked growth. Sometimes we're not exactly sure how this affects the cancer. It may be associated with worse prognosis. And we actually now have therapies that are available that target these proteins. An example are antibody drug conjugates that are approved in the setting of high levels of MET on the surface of the cancer, what we call MET overexpression, as well as antibody drug conjugate that targets HER2 overexpression. In addition, we can stain for these markers for patients to assess benefit of immunotherapy in those that don't have classical driver mutations. And that's where we assess for PD-L1. So these are just an example of the type of alterations that we look for when we talk about molecular testing. So how do we test for these alterations? So let's go back in time first to some of our older methods, and that was single gene testing. So this was utilizing a technology called real-time polymerase chain reaction, or RT-PCR. Basically, what we would do, we would take a small tissue sample, digest it, and utilizing specific markers, specific probes, we would assess for a specific altered gene in the cancer. Now, there are actually newer iterations of this technology that are more efficient and actually can be very rapid. So I would say this testing is evolving, but it's not what we use on a go-to basis in most cases. A positive is that this has been around for a long time, so it's fast. Most labs have it available and it's cheap, but it does miss rarer alterations and other alterations such as gene fusions. And it really is not an efficient use of tissue. If you need to use one small tissue sample to assess one alteration, you can imagine this is precious tissue. You can run out quite quickly. There's another type of test called fluorescence in situ hybridization, or FISH. This utilizes special probes that target specific places on a chromosome where a specific gene of interest is. And then it's viewed under a particular microscope so that basically those areas will light up. This can detect gene amplifications where there's more than one copy of a gene, as shown in kind of the pane B on this figure. And it can also importantly detect gene fusions. So again, when one of these genes fuses with another, we can see that utilizing this specific type of testing called FISH testing. Now, pros are that this also is fast, in-house, and cheap in most cases. Excuse me. However, it can be technically challenging, and it too is an inefficient use of tissue because you are using one tissue sample to do this particular type of test. Let's move on to immunohistochemistry. And while this is an older type of test, it still has a role in today's day and age. This utilizes particular antibodies to stain certain markers on the surface of the cancer. So this can be utilized to detect where a cancer originated from. So there are certain markers that suggest that a cancer came from the lung or from the breast or from the GI tract, etc. It also can stain for certain proteins that are important in determining certain therapeutics. So probably the biggest example of that is PD-L1 that is shown on the right on this slide. So different degrees of PD-L1 expression in certain types of lung cancers can predict benefit to immunotherapy. We also can test for MET and HER2, as I said before, to test for certain what we call antibody drug conjugates, or kind of smart chemotherapies to test benefit of those treatments. This is fast, in-house, and cheap. And again, it is utilized quite a bit still today, but an important, I guess, relative massive caveat or weakness is that there is some variability of interpretation here. What one pathologist says is high degree of staining, another one might say moderate, so there can be some variability in the interpretation. Next is next generation sequencing. This is probably the most modern platform that we utilize now to assess for alterations in the cancer. This assesses thousands of genes and gene transcripts called RNA to identify your mutations, your insertion deletions, your fusions, your amplifications, most of the alterations that I talked about earlier. There are many platforms that are used. There's Tempest, Foundation Medicine, Caris, Garden, just to name a few. Importantly, there are both tissue and blood platforms to assess for these alterations. And at least in tissue, the RNA testing component is quite critical to identify those fusions. Based off of how those alterations happen, that part of the testing can be very important in detecting these fusions. Shown on the right is a graph that specifically shows how incorporating the RNA-based testing increases the likelihood of finding one of these fusions. Now, most of today's modern platforms does utilize RNA-based testing for the tissue testing, but this is an important point. Another advantage is that most of these commercial platforms are kind of a one-stop shop where they do the IHC testing, they do the FISH testing if you need it. So you get the tissue, you send it to these companies, and they will do this testing. The pros then are that it's comprehensive. Again, one-stop shop, it's efficient with tissue, but it does have a bit of a longer turnaround time for the tissue testing. That's probably on the order of about 2 to 3 weeks. It's getting better. It is expensive, though covered by most insurances. And it does require higher quality tissue. Now, I mentioned that this type of molecular next generation sequencing testing, there is both blood and tissue testing that we can utilize. And these are complementary, and they oftentimes can test the same thing. The blood looks for actually a cancer DNA that's shedding into the bloodstream to look for these mutations. So the pros of that are it's non-invasive and it turns around much quicker, oftentimes on the order of about 1 calendar week. But it doesn't detect everything. It can't do the IHC, the markers on the surface of the cancer, and it sometimes is not as good at detecting the gene fusions. The tissue testing can assess all those things, but you do need a certain amount of tissue, and again, the turnaround time is a little bit longer. So how do we determine which one to do when? This is just an algorithm that one can utilize on determining the order of tissue testing versus blood testing. In my practice, I like to try to get both at the same time because if you get an answer on the blood testing, it comes back quicker. You can oftentimes then proceed with appropriate treatment. However, if depending on insurance coverage, et cetera, you can always go in order of tissue and then blood. However, I just want to try to prioritize and get these answers back as quickly as possible so I know how best to treat my patients. Important in blood testing, and you may have heard, so it's important to clarify what's the difference between our molecular circulating tumor DNA testing or ctDNA testing and what we call minimal residual disease testing or MRD testing. So what are these different tests and what do they look for? So your molecular profiling circulating tumor DNA testing, this is what I said earlier, like your classic Garden test, and then Tempest and Caris have their tests as well that are really looking for those cancer mutations to assess appropriate therapy. It's off-the-shelf testing. It has a relatively quick turnaround time. There can be a false negative if there's a low burden of cancer in the body or a low what we call shedding of the cancer DNA into the bloodstream. And again, it supplements our tissue testing to profile the cancer. MRD testing is different. It looks at the most microscopic level. Is there evidence of cancer that we can detect in the body, yes or no? There are two forms of personalized, what we call tumor-informed testing, where you take the tumor tissue and you create a kind of a test specific to that patient that you could test in the blood. Then there are some off-the-shelf tests that look for particular signatures of cancer in the blood. Now, this has a longer turnaround time, at least for that tumor-informed kind of personalized approach. And there can be false negatives with varying degrees of sensitivity of the assay, meaning various abilities of the test to actually detect a cancer at a microscopic level. And this is an evolving technology, and importantly, with unclear clinical applications. So what do I mean by that? What are the challenges? So I mentioned limited sensitivity and specificity, but also we don't know, what's the appropriate interval to perform this testing? And if we get information, how do we act on it? So if this test is negative, what does that mean for continuing a therapy? If someone had their cancer removed by surgery or treated with chemoradiation and it was negative and it now becomes positive, do we start treatment again? For how long do we keep that treatment going? These are answers that we don't have. And again, it can be falsely negative. On the right, I show an example of this type of test done in the phase 3 ADORA trial. That was the study of adjuvant, meaning osimertinib after surgery in patients with EGFR mutations. And it might be hard to see depending on how big your screen are. But what I highlight here are examples of where this test was negative and then it ultimately turned positive. So it tells you that when it was negative, it was actually a false negative test. So how do we appropriately use this information? There are multiple clinical trials that are ongoing incorporating minimal residual disease testing or MRD testing, but I would say it's not quite ready for prime time yet, and I think should not be utilized on a routine basis for treatment decision making. So let's move on to some more questions. True or false? If a biopsy is performed of a cancer spot in the bone, this specimen can be utilized to complete biomarker testing with next generation sequencing NGS testing. The answer to that is false, usually. What I mean by that is that the typical process for processing the bone, called decalcification, can damage the DNA, making this NGS testing not possible. There are special methods, though, utilizing certain solutions, certain acid-based solutions that can preserve the DNA. But basically, an institution has to have these protocols in place. So if you do have a cancer that only has one bone spot, it's important to clarify, are you able to process this bone specimen to get the testing done, or do you also need to biopsy the primary spot, for example, in the lung, to get the answers we need? Next question, true or false? Having molecular testing results back to inform our decision making. Whoops, I have to show the question. Having molecular testing results back to inform treatment decision making before starting treatment is associated with improved survival. The answer to that is true. We've actually seen published results to suggest that if you have your testing results back and you get someone on the most personalized treatment for them, that there's better survival. Now, obviously, there is confounding in this. If someone is really sick and you need to start treatment right away with chemotherapy, they may not do as well as someone that can afford to wait for these results. But either way, this shows that having these results back to guide treatment is incredibly important and may be associated with improved survival. Another question, yes or no? I've heard these mutations are more common in younger patients who have never smoked before. If I'm older or have a history of smoking, should I still have biomarker testing performed? And the answer to that is absolutely. Cancer does not read a particular playbook, even though, someone who has a minimal smoking history may be more likely to have one of these cancer mutations. It's not absolute. And an example of that are the demographics from the phase 3 FLORA-2 trial that looked at osimertinib plus chemotherapy versus osimertinib targeted therapy. And you could see in this alone, the oldest patients were in their 80s. The oldest patient I've had with an EGFR mutation was over 100. In addition, you could see a third of patients enrolled to the study had a current or former history of smoking. So again, you shouldn't let demographics dictate who gets this testing. Everybody should get this testing. Another question, yes or no? If I have my PD-L1 results back, remember this can be utilized to predict immunotherapy benefit, while waiting for our full molecular testing results to be finalized, can we start immunotherapy? No, 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 absolutely not. We know that in a lot of patients with certain driver mutations, immunotherapy is not effective. And if you start immunotherapy first and then move on to appropriate targeted therapy, it can lead to enhanced likelihood of toxicity. So this is just an example, particularly in the EGFR and ALK mutation space. You could see on the left, those with these alterations, low likelihood of benefit to immunotherapy. And on the right, specifically looking at untreated EGFR mutated non-small cell lung cancer with immunotherapy. Each one of these triangles represents the time point when the immunotherapy was shown to not work and where the cancer was growing. And you could see this happened within a few months of starting the treatment. It was not effective. And in the one patient where there was benefit, that patient did not have an EGFR mutation. But this is not all cases. So this is an example of MET mutated non-small cell lung cancer. That is a case where we do think immunotherapy with chemotherapy combinations likely has benefits. So it's just to say that this is not the case for all mutations, and you really need this information back before starting appropriate treatment. And again, if you start targeted therapy after immunotherapy, this can have devastating consequences. Not only may it not be effective, but you may have severe reactions, liver side effects and toxicity, inflammation in the lungs, just to name a few. So you really need the molecular testing results back. It's important to wait for the results before starting appropriate treatment. Next, yes or no. If the cancer is growing again on targeted treatment, should I have another biopsy done to perform biomarker testing? And the answer here is yes. The mechanisms of resistance to targeted therapy are diverse and potentially have other targets. So on the left is on-target resistance. This happens when there's another mutation in the gene that's altered that makes it so that the targeted treatment can't bind and block the signal well. And in this setting, there may be newer options available, clinical trials or chemotherapy. Sometimes there's another pathway that becomes activated. I mentioned MET before, BRAF. There are other pathways that may become activated where you could add an appropriate targeted treatment or again pursue a clinical trial. And rarely we can see transformation of the cancer where it becomes a more aggressive subtype of cancer, such as small cell lung cancer. And in this setting, chemotherapy is incredibly important. But you will only know the mechanism of resistance if you profile the cancer again. And that's why repeat biopsy is so important. So, what can you do? Ask and advocate for molecular testing to be done at diagnosis and prior to starting cancer treatment. It may feel anxious to have a diagnosis of cancer and feel like you're waiting, where like I should have started treatment yesterday. But in most cases, it's more important to wait for the right therapy than to start the fastest therapy. If there is a bind where there's significant symptoms, one can always get a round of chemotherapy while waiting. But again, you need this results back before starting an immunotherapy-based treatment or targeted therapy. It's incredibly important. And again, repeat biopsy and molecular testing, if the cancer is growing on targeted therapy, is incredibly important so we can try to assess why the cancer is growing again to then find the right treatment for you. So with that, I'll thank you for your attention. My email is here. Feel free to reach out to me anytime if you have any specific questions, and I'll look forward to taking questions later. Thank you so much.
Hey, thank you so much, Dr. Royce. As I mentioned in the beginning of this webinar, we're gonna leave the question to the end after all the presenters did their presentation. So next, it's my distinct pleasure to introduce Dr. Amanda Herman, who is an assistant clinical professor and a thoracic medical oncologist from the best institution on earth, University of California, San Diego. So she is my wonderful colleague, and she will be discussing on how you as a patient can look at your molecular testing report and what things you need to be paying attention to and how to decipher the alphabet soup of what is seen on the molecular testing report. Go ahead, Dr. Herman.
Thank you so much, Dr. Bazhenova. I'm just going to get my slides here. All right. Thank you again, Dr. Bazhenova, for the introduction, and I'm so happy to be here today to talk to you. Again, my name is Amanda Herman. I'm an assistant clinical professor and thoracic oncologist at UCSD, and I'm happy to talk to you today about decoding your molecular testing report because these reports can be shared with you in a packet of information that can be very complex and difficult to interpret. And so we'll break down a little bit of that today. So an overview and very brief introduction. Dr. Royce just did a fabulous job. And so we will just very, very quickly touch on a little bit of background information. And the main portion of this talk will be breaking down your molecular testing report. We'll look at how to interpret the next generation sequencing reports, the immunohistochemistry, what it means when it says there's a variant of uncertain significance, some questions to ask your doctor, and a few summary and resources at the very end. Okay, so what is molecular profiling in lung cancer? We did just spend a great session talking about this, so we'll just brush over this, but we know this is a set of comprehensive tests that characterize your tumor's genetic makeup and identify specific changes and biological markers that drive cancer's growth and predict response to therapy. We're looking for specific changes in the genetic makeup of your tumor, not your genes, but the tumor's genes that impact the way the cancer acts. And we think of this sort of like a roadmap to your cancer's unique features. So why do we need it? Why do we sometimes need to wait until your molecular testing is back to decide on a treatment plan? This is allowing us to personalize your cancer treatment. The molecular profiling gives us a better understanding of the biology of your cancer, and that allows us to select the most effective possible treatment for you and your specific cancer. It allows us to identify actionable changes that may be responsive to therapies that are designed specifically for the genetic makeup of your tumor. And what does actionable mean? You may hear your doctor say you have a driver mutation or an actionable mutation. Actionable means there's a medicine that's specifically designed to target that gene or change or protein marker. Again, this provides us predictive and prognostic information about your cancer, and this is a better understanding of the biology of your cancer. It's telling us how certain genes work together, how certain markers predict how your cancer will respond to different types of treatment. And of course, to avoid the use of ineffective treatments. We're ultimately looking for the best treatment match, and matching the treatments to each molecular profile has been shown to improve both survival rates and patients' quality of life. So how is it done? We just talked about this in great detail, which was so informative. And there are many different laboratories and platforms that perform the tests that make up molecular profiling in lung cancer. And I mention this because we're going to look at some specific examples, and your reports may look a little bit different than the examples that I show. But in general, we're looking for the same outcomes, the same certain tests and certain mutations and markers that are helpful for us. And sometimes it can be done in a lab at your hospital. Sometimes it's sent out to an outside lab. Usually several tests are done at the same time, each looking for different kinds of information. And then your doctor is likely going to use multiple methods, and the results of those methods combined together to increase the chance of finding all of the changes that might be actionable or treatable. So some of the most common tests that you'll see in your molecular report include NGS, or next generation sequencing. Again, this reads the genetic code of your tumor, looking for many gene changes at once, looking for mutations, fusions, amplifications, deletions, other biomarkers in the genes. And again, there are DNA and RNA-based gene testing. These are two different types of genetic material, and looking at the two together is the best way to get a complete picture of what might be driving your cancer. One of these tests might detect a finding that the other might miss. We have tissue and liquid testing. The tissue, we're extracting the genetic material from the tumor itself, whereas in the liquid, we're looking for those tumor fragments that are shed into the blood, or the circulating tumor DNA. And again, we have immunohistochemistry, fluorescent in situ hybridization, FISH, and polymerase chain reaction, PCR. These are just words that you may see on your report, and you can refer back to this as sort of a reference. So what's your doctor looking for? We're looking for actionable gene alterations, genetic changes in the tumor that have FDA-approved targeted therapies or therapies that are available in clinical trials. There are a few common actionable alterations in lung cancer in genes such as EGFR, ALK, ROS1, BRAF, KRAS. And this includes changes that are thought to be the primary driver of cancer growth. You may hear your doctor say a driver mutation. Also looking for the co-mutations. They're gene changes that are found alongside the primary mutation. These can influence the way that your cancer will respond and which treatment might be the best fit. PD-L1 expression, this is a protein marker that may help your team decide if immunotherapy is a good choice for you. And other complementary markers, things like how much burden of mutation is there in your cancer's genetics, other protein markers on the tumor cells, extra copies of genes, and loss of copies of genes. So again, as I mentioned, there are many different companies and platforms that do these tests. So your individual reports might look different, but regardless of the platform, I find that because we're often testing for many genes and biomarkers at the same time, the results are complex. They're often shared with you and your doctor in this form of a multi-page report with lots of scientific jargon, and that can be really overwhelming to wade through and understand. So let's break down just a couple of the most common findings that you might want to look for if you're looking at one of these reports. So this is an example of the first page of one particular molecular report. It's the results of the next generation sequencing, or NGS, of the DNA. And this is one of those comprehensive tests that we were talking about that's going to help us look for actionable mutations and other biomarkers. And right away, we're faced with what appears to be a lot of complex information. So we're going to zoom in at the top of the page. And this includes some information about actionable gene alterations, co-mutations, and some pertinent negatives. So this is that same page. We're zoomed in at the top. On the left, you can see there's some demographic information, some information about the test and the sample. And looking at that section, we can see that this is the DNA test. They looked at 648 genes in the cancer's genetics. And then it tells you about the tumor specimen. That's what was tested here. In this case, it was lung tissue, meaning this is a tissue biopsy. It might say blood. It might say a blood sample. It might say a lymph node. It will give you information about what was tested. So over to the right, we have our first large section that's called genomic variants. And this is really the meat and potatoes of this page. This identified that this particular sample has a potentially actionable mutation in EGFR, meaning there is an existing FDA-approved targeted therapy for this mutation. And the other information next to the EGFR tells us the specific change in the cancer's DNA. So the P-L858R is basically the shorthand, the scientific shorthand for the DNA error. The P stands for protein, and L858R indicates the exact position and type of change in the DNA building block. And this is giving your team information about how that change might be driving your cancer growth, and if there are specific drugs that can target a change like that. And in this case, they're saying, oh, there's something potentially actionable here. Next, this test has also identified 2 biologically relevant mutations in RBM10 and TP53. And these are genes that likely affect how the gene functions and probably contribute to the cancer development, but don't necessarily have an approved targeted therapy. Next to this on the right, we see the VAF, or variant allele fraction, and that's telling us the percentage of DNA reads at a specific location that contain that particular mutation. So when the lab sequences your tumor, they read the DNA at each location thousands of times, and this tells us what percent of those reads showed the mutation versus normal DNA. And there's not a specific cutoff that tells us whether a treatment will be effective or not. But in this, the higher the VAF, the more confidence we have that the mutation is present in more cancer cells and could potentially be driving the cancer's growth. Down at the bottom, we see pertinent negatives, and these are genes that were tested in that 648 gene panel that were found to have no mutations. And so remember, in lung cancer, there's about 10 to 12 specific genes that we're looking for that if mutated, we might have targeted pills or specific targeted drugs that could be effective. And so your report's just telling you we've tested for these, and these ones are negative and or came back as normal, meaning not mutated. So still going back to again, this is still that first page of the DNA NGS report. We're going to look to the bottom of the page where we have results that look for complementary DNA markers that may predict a response to immunotherapy. So here we have 2 biomarkers, again, that predict how well your cancer might respond to drugs called immune checkpoint inhibitors or immunotherapy. And first on the left, we have something called TMB, or tumor mutational burden. And this asks, apologies. This asks us how many genetic mutations are in your cancer's DNA, and it's expressed in a number of DNA mutations per megabase. And when cancers have lots of mutations, they produce abnormal proteins that look foreign to your immune system. And so the more foreign your cancer appears to your immune system, the more likely your immune system is to recognize them and attack them. So high TMB, or greater than or equal to 10 mutations per megabase, means your cancer has many mutations and may respond better to immunotherapy drugs. Less than 10, your cancer has fewer mutations, and immunotherapy may still be effective, but the response rate may not be as robust as if you had high tumor mutational burden. On the right, we have something called MSI, or microsatellite instability, and this asks how many errors are there in short sequences or microsatellites of your DNA. This is not used as strong of a marker in lung cancer. MSI high means that there are many errors. The microsatellites, or those short sequences of DNA, are considered unstable, and it may respond well to immunotherapy, but this is pretty rare in lung cancer. Microsatellite stable or fewer errors is typically what we find, and we rely more on markers like TMB and PD-L1 to guide our decisions on immunotherapy. So moving to page 2 of this particular report, again, we have results of next generation sequencing. This time it's the RNA rather than the DNA. And so we'll look up to the top portion where we have actionable gene alterations and FDA approved targeted therapies. So what do these sections mean? So similar to our DNA NGS, on the left, we're finding demographic information and information about the test and the sample. In this case, we're testing RNA or the RNA transcriptome, which is saying that this is a snapshot of which genes are turned on and working in your cancer cells. And this, again, it was a tissue sample from a lung biopsy. And so looking over to the right to the genomic variants, this test identified a potentially actionable alteration, meaning a drug exists. And the alteration is an EML4 ALK chromosomal rearrangement. And we often refer to this as a targetable ALK alteration and ALK fusion. And that's because ALK is the gene that's relative to the lung cancer, but it's really representing an abnormal fusion between EML4 and ALK2 genes. So now to the bottom, and you may find on whichever kind of report you're looking at that when these genomic variants that are potentially actionable are identified, they include a list of FDA-approved therapies or something similar. And this section lists drugs that are approved for cancers with the specific genetic changes that are found in your tumor. And it's important to recognize this is really just a reference list. The drugs on this list may not be the right drug for you or even the best available option. Sometimes there are newer drugs, there are clinical trials, there's combinations of therapies that are better choices, and some things that your doctor's thinking about. Many of the drugs that are listed here may be approved only after other treatments have failed. Some drugs are approved for a mutation only in certain types of cancer that aren't relevant to the type of cancer that we're looking at. Some drugs are given in combination with other drugs. The other findings, the co-mutations or your overall health and certain side effects of drugs may impact the choice that your doctor is making. So we'll close out this section on the DNA and RNA NGS with one final point. Even if your NGS report shows no targetable mutations or says something like the patient does not qualify for any clinical trials or no reportable treatment options found, that can sound very daunting. This does not mean that there are no treatment options. When we don't find certain mutations like EGFR and ALK, this often opens the door for different types of treatment options like immunotherapy. Your doctor might recommend immunotherapy alone, immunotherapy combined with chemotherapy, chemotherapy alone, a clinical trial. There are usually lots and lots of options. And when the test says that no options were found, it's usually very specific to a certain finding that was not identified. And so your doctor is going to look at other molecular tests to help guide their treatment choice. So one example of that is our PD-L1 testing. And you somewhere on your report, you will likely find an area called PD-L1. And this is immunohistochemistry, which is a certain lab test that's used to detect PD-L1. And PD-L1 is basically a protein that some cancer cells express on their surface. And I like to think of it like a shield that helps your cancer hide from the immune system. When PD-L1 is present, it tells your immune cells, don't attack me. So we're going to look on your cancer cell surface for this expression. So let's zoom in on the top portion of this page where we find the PD-L1 expression level. So again, we're on the PD-L1 page. We're going to have demographic data, some data about the test sample. And then over to the right, we'll see the PD-L1 expression level. And again, this is helping us understand how well your cancer might respond to immunotherapy. And you will see there's two different scoring systems for this, and both will often be included on your report. There's one called TPS or tumor proportion score. You may also see one called CPS. We tend to use the tumor proportion score or TPS more commonly in lung cancer, so I'll focus on that one. And this is telling us what % of tumor cells express that PD-L1 shield. And your PD-L1 score will fall into one of three main categories. And that is high, meaning more than half of your cells are expressing the PD-L1 shield. And studies show that patients with high PD-L1 have the best response rates to immunotherapy, again, considering other mutations and things that are also looked at in these reports. Intermediate or low, from 1 to 49%. Some of your cancer cells express PD-L1, but not the majority. And so your cancer may still have a very good response to immunotherapy. It may be combined with other treatments. And again, when PD-L1 is negative or less than 1%, it means very few cancer cells have that PD-L1 expression. But this does not mean that immunotherapy won't work for you. It's just that typically if we're going to use immunotherapy, we combine it with other treatments like chemotherapy in that situation. And again, at the bottom, the little asterisk just says, remember remember that we're interpreting this result in the context of the entire molecular testing report. So even if you have very high PD-L1 expression, if there's one of those other mutations that could indicate that you wouldn't respond well to immunotherapy, or that the combination of those drugs with targeted and immunotherapy would cause severe side effects, it still may not be the best choice for you. So it's a good idea to look at this and then ask your doctor to how they're interpreting these results in the whole puzzle of how of all of the results that are coming back in this report. So there are other tests that may be included in your report, and I'm going to point out 2 other immunohistochemistry tests that are commonly being done now in the setting of new drugs with these findings. So aside from PD-L1, immunohistochemistry can be used to detect HER2 and MET protein expression on your cancer cells. And while mutations in HER2 and MET may be found in your NGS reports, or next generation sequencing reports, expression of these proteins on the surface of the cells can be tested with immunohistochemistry. And both of these, depending on the expression level, may be actionable, meaning we have targeted treatments, sometimes antibody drug conjugates that can be used to target when there is overexpression or high levels of expression of these proteins on the cell surface. So both MET and HER2 are protein receptors on the cell surface, and their results may be expressed in this immunohistochemistry section on a scale of 0 to 3+, with high expression being 3+. And so it's important to take a look at these sections and ask your doctor how these findings contribute to the choice of therapy. One other area you may see listed on your report is called variants of uncertain significance, or VUS, and they'll often list this with a number of gene mutations underneath. This is what kind of a scientific gray area. They're genetic alterations that have not been definitively classified as disease-causing or benign based on currently available evidence. We don't have enough literature, enough data to tell us exactly how they're impacting the cancer growth, or if we don't have targeted therapies for these drugs yet. For these mutations yet, and they're not currently used to guide treatment, but that could change in the future. And here I just included a couple of questions to ask your doctor. These, looking at these reports can be very complex. And obviously, as you can see, there's a lot of different components that go into ultimately choosing a treatment regimen. And so this is sort of a reference of some questions that might help start a conversation with your doctor about the report that you have received. What mutations were found? What's the best option based on these results? Are there targeted therapies approved for these specific mutations? How might my cancer respond to immunotherapy? Should I consider a clinical trial? And how do these findings shape the treatment plan? It's also important to ask if any of the findings have implications for family members. Usually these mutations that we're finding in the genetics of the tumor are not things that are passed on to family members, but sometimes we find mutations that may be something that are what we call germline, or in your own genetics that could be shared with family members. So your doctor can help you understand whether or not that's an important consideration. And then last slide, just to summarize, molecular profiling is a comprehensive testing of tumor tissue or blood, or both, usually, to look for specific gene changes. And these reports are complex, often many tests sent at the same time, but they help us have insight into what's driving your cancer to grow and what treatment would be the most effective for you. Remember that if it says there are no mutations, it does not mean there's no treatments, and there's lots of support. Your medical team can help you to interpret these results. And there's also I included some links here to some patient resources on understanding biomarker testing. And that's all. Thank you so much.
Thank you so much, Dr. Herman and Dr. Royce. Okay, so we have some time for Q&A, actually exactly 20 minutes. And thank you both for staying on time with your presentation. That's always a challenge when you present, especially such a complex topics. We have a lot of questions coming up, and for our audience, some of those questions are actually going to be discussed in the next session. So I will leave those questions for next speakers, but some of them I will go ahead and start. So the first question is, what are the potential side effects of the biomarker testing procedures? And so we've talked about what the biomarkers, but what does it take to get to that molecular report? And whoever wants to take it, just go ahead and start.
Okay, I guess I can jump in. So, frequently, it's a good question. Frequently, there is really not a lot else that's needed. If you've had a biopsy of the cancer and sufficient tissue is taken, and the testing was done to identify where the cancer started, if it was a biopsy of another site, we oftentimes try to ask our pathologist to limit this extra testing to, if we think it's a lung cancer, do the minimal testing needed to show that yes, this originated in the lungs, so we can preserve tissue for this testing. And if there's enough tissue, no more procedures are necessary. If we do the blood testing, it's just a blood draw like other blood draws that you have done at your doctor's office. Now, sometimes we might need to repeat a biopsy. And if we do, it all depends on what site's being biopsied. If it's in the lungs, that frequently requires a bronchoscopy, which is, you're sedated, put to sleep, and they take a kind of a tube device down the throat into the lungs to do a biopsy. If it's a spot in the liver, it may be a biopsy kind of on the outside of the skin using imaging like CT or ultrasound to biopsy a spot in the liver. So obviously each one of these procedures has potential complications, pain, bleeding, infection risk, etc. But it all really depends on what spot is being biopsied.
Thank you. Another question I think maybe Dr. Herman, I'll put to you because you started that discussion. So one of the questions coming in is my mutation hereditary? Should my family be tested? How do we know based on, let's say, liquid biopsy or tissue biopsy that this mutation is hereditary? And how do you make a decision? So you mentioned that your doctor might refer you to genetic counseling. How do you make a decision if your patient needs to be referred to genetic counseling?
Yeah, so it's a great question. And there are two types of mutations that we can find. Somatic mutations, which are changes that occur only in the tumor cells, and what we call germline mutations, or the types of mutations that are inherited. They're in other cells in your body as well. And it can be difficult to tell on a molecular testing report alone, but sometimes there are clues. So the variant of allele fraction can sometimes give us an idea of this. If it's a particular percentage, very close to 100% or very close to 50%, it might give us a clue that perhaps we should look further and do germline testing. Also, there are certain genes that tend to be more commonly encountered in the germline setting, things like the BRCA gene, which you may have heard in reference to breast cancers, other genes that are more commonly found as germline mutations, and also sometimes clinical features. If a patient's very young, has a never smoking history, has multiple primary malignancies, it would give us an indication that we might want to do more extensive testing to determine whether any of these mutations are germline or ones that can be passed to family members. And you can ask your doctor, and I would be interested to hear if Dr. Royce had other thoughts about that as well, or if there's other findings that you look for to help determine. But if your doctor's concerned or has a suspicion, they'll probably talk to you about it and refer you to a geneticist to look at do germline genetic testing more closely.
Yeah, no, I agree with everything you said. And I think actually, if anything, it may not be the mutation in the cancer that causes one to be referred to genetic counseling, but we may pick up like an incidental BRCA alteration or an alteration associated with Lynch syndrome. So sometimes it might not even be the mutation of interest for cancer treatment that leads us to refer to genetic counseling. But it's definitely an important, I think, question to ask when this report comes back. Ask your provider, do you know if any of these genes could be hereditary? And if I need to see a genetic counselor, that's always an important question to ask.
Thank you. So another question, Dr. Royce, I'll push it to you. So, because that was kind of what you discussed. So, are there any limitations to your biomarker test? And maybe you can specifically highlight the false negative rates of a liquid biopsy, because I still see patients just getting a liquid biopsy done and told that they don't have any targetable alteration without pursuing tissue diagnosis. And in what situation, you touched a little bit upon that. I'm going to add my own question. Um, Insufficient quantity for next generation sequencing on the tissue. When do we push for another biopsy? How we decide? So if you can just highlight the limitations of the testing.
No, absolutely. Great questions. And I think, at least for the liquid biopsy for the blood, and this is specifically, again, focusing on the testing to assess for mutations, right? Which is different than the minimal residual disease or MRD testing that I talked about, which is I still don't think exactly ready for prime time. That's just looking at microscopic evidence of cancer in the body. But if we again focus on the DNA testing for liquid biopsies used to detect cancer mutations, again, you may have heard of this with Guardant, but there are other platforms, Tempest Foundation Medicine, Caris, et cetera. We can see false negatives if there's essentially if the cancer itself is not shedding the DNA into the bloodstream. And in that setting, let's say the test comes back and says no mutations reported. Well, if we don't see a high burden of cancer in the body, or we don't think the cancer is shedding into the bloodstream, then I am not, I don't view that result as adequate. Also, sometimes we can see what we call, and I think Dr. Herman commented on this, variants of undetermined significance, or we can see alterations that might just be present in the blood because, one's blood might have alterations that just kind of come with time that might be reported on this test, but it's not indicative of what's in the cancer. So, if I see a result in the blood and it doesn't have what we call a targetable mutation, like let's say it has a mutation in KRAS, which is commonly altered in lung cancer, such as what we call a G12V or G12A and maybe a TP53, alterations that we commonly see with non-small cell lung cancer. Well, in that case, it may not show a mutation, but it's helpful to me. It suggests that yes, I'm getting the picture of what's going on in the cancer. I might need a few extra tests from the tissue, but the result is informative. But if it says none detected or just a few what we call variants of undetermined significance, then I really want the tissue testing. And yes, as Dr. Bazhenova said, like sometimes the tissue quality may be insufficient for mutation testing. And, if I didn't get an answer in the blood and I don't get an answer in the tissue, I really feel strongly that we need to repeat a biopsy. Now, let's say someone is sick and you feel like you need to start something. Again, one can start chemotherapy, but I really don't want to proceed with treatment unless I have that result because it's informative, even if you don't find a classical activating alteration. There are some mutations that we look at that may predict for benefit to certain immunotherapy regimens, for example. So if I don't get a result that I am confident gives me the answer I need from either tissue or blood testing, in that setting, I really think you need to repeat a biopsy.
Mhm. To piggyback on that question a little bit, so question to Dr. Herman. So what if you have a patient who have a very heavy smoking history and current smokers? Or, for example, if you have a patient with a squamous cell carcinoma, do we do testing on those patients? And is there any patient population in stage 4 non-small cell lung cancer where testing is not indicated?
No, I would say we would recommend molecular profiling no matter who you are. If you have, advanced and metastatic disease, even in the early stage setting, we're doing this more and more frequently, but regardless of the histology, regardless of the patient characteristics. I may have a lower suspicion that we might find a targetable mutation in certain populations, but I recommend testing everybody, regardless of whether the likelihood is higher or lower of finding these mutations. Because if we are to find a mutation, and there's still a portion of patients in each of those groups who will have a targetable driver mutation, we can find a treatment option that is more effective, that may come with fewer toxicities. It also guides us to not use it to avoid ineffective treatments and to avoid combinations of therapies or sequential therapies that could result in significant side effects or toxicities that can be life-threatening. And so sometimes, again, I think this has come up, Dr. Royce mentioned it as well, that it can feel really stressful to be sitting and waiting, a week or 2 weeks for molecular testing to come back. But when we're able to, waiting for those results, regardless of the patient or the history, it can provide such valuable information about the most effective way to treat. And studies have been, our studies and data support the fact that we're improving both survival outcomes and patient quality of life by targeting our treatment and personalizing our treatment with these tests. So in my practice, everybody is tested regardless of their background or the histology of the cancer.
All right, thank you. And so you said something that there is actually a question about that. So I'm going to hand it to Dr. Royce. So We've talked about molecular markers in helping us making treatment decisions, mostly for patients with stage 4 non-small cell lung cancer. Do molecular marker testing have a role in early stage lung cancer, for example, stage 1, stage 2, stage 3? And I think a very important question, is that going to be covered by the insurance? And I think, the answer to the insurance question will be different depending on what state you are. But what's your practice in testing non-metastatic patients? What test you use, who you use it for, and how do you approach that?
Yes, absolutely. And I think this was my cold open true false question that absolutely this biomarker testing is critical now at all stages of disease because most the way that kind of drug approvals work in lung cancer and probably in other cancers too is that the first approvals are in advanced disease and then they kind of trickle down to earlier stages of disease because we need randomized studies to show that there's benefit in all stages of disease. And in earlier stage disease, thankfully, patients live longer because more people are cured. But because of that, it takes longer to see the benefit. But regardless, we now have approvals, for example, of osimertinib in the EGFR mutated lung cancer after surgery, alectinib for ALK fusion positive lung cancer after surgery. We have chemoimmunotherapy regimens that we give both before surgery, after surgery, and combinations of. That's in the surgical space. We have in patients that can't get surgery with chemoradiation, immunotherapy is approved, but we also have osimertinib approved for EGFR mutated non-small cell lung cancer. And so again, just like advanced disease, you need the biomarker testing done to know what is the most appropriate treatment for your patients. And I actually think that now, again, in the earliest stage 1, like a stage 1A, is there really a role for these treatments? Probably not. It's confusing because the FDA approval, for example, for osimertinib after surgery just says EGFR mutated disease. It doesn't specify stage, but we definitely don't have data for these targeted therapies for anything earlier than a stage 1B. So I don't think there's necessarily a role there. I mean, it's same with chemo and immunotherapy for that matter. But you really need the biomarker testing, particularly for stage 1B and higher. And it's very hard if it's done, kind of in the neoadjuvant setting before surgery, because oftentimes the biopsy specimen is more limited. You need that specimen to assess kind of where the cancer originated from. So in that setting, you may actually, it sounds sacrilege, but we may do a more limited panel testing to at least rule out the more pertinent treatment decision-making genes. But that was a very long-winded way of answering, yes, you need to do this testing in all stages of disease.
Yeah, and I think I want to highlight something that you say, which I think is very important. So for the very early stage lung cancer, you use the 1A, 1B. So for the patients on the audience, that means that the tumor did not have any involvement of the lymph nodes and was less than 3 centimeters, because all our data on benefit of adjuvant therapy starts with tumors over 3 centimeters. So, don't ask your physician for the molecular testing if you have a 2 centimeter tumor primary resected, because there is no data we can at this point. There are ongoing trials with osimertinib, which is going to answer the question if osimertinib is beneficial in the very early stage lung cancer. But everything more than 3 centimeters or involvement of the lymph nodes, I think cannot say it better enough, and better than Dr. Royce just said. Definitely testing is indicated. Another question I think is kind of interesting, because I think we convinced everybody that biomarkers are very, very important. And the people are asking, should I get tested more than once just to be sure? Like, for example, if you see in a patient and they have an NGS at, let's say, Tempus, should you run an NGS in Caris? Should you run an NGS in let's say, Foundation Medicine? Like, when do we test them again?
So,
Dr. Herman, go ahead.
no, that's okay. I think most of these the platforms that do the comprehensive genomic profiling, Tempus, Guardant, Foundation, most of them are doing many of the same tests. And so, at the same point in your treatment history, I don't think there would be a benefit to do multiple tests at different platforms. I think you're getting much of the same information, but I do think repeating molecular profiling has a growing role as when cancer progresses. At the time time when a cancer is no longer responding to a certain treatment, particularly if you've had a mutation, an alteration that we used a targeted therapy for. Oftentimes, the cancer can be tricky and develop a resistance mechanism. So they'll develop a new mutation either in the same gene or in a different gene that allows the cancer to grow. Now that it's basically like the flu when they have to change the flu vaccine every year because the flu has morphed, your cancer can do the same thing. So the cancer can change, can develop new mutations that we might want to look for once the cancer progresses. So your doctor may recommend a repeat biopsy at the time of cancer progression, repeating both the liquid and the tissue molecular profiling, or the blood and the tissue sampling, to see if new mutations have arisen in your cancer, or if there's been a change in the type of cells that can guide our next treatment decision. But I think if no mutations are found in a certain panel, or certain mutations are found in a certain panel at that same time point, I wouldn't recommend necessarily doing a different platform.
Let's go
Sorry. I
ahead,
was gonna
Dr.
say, the
Roy.
only
Go
thing
ahead,
I
go
would
ahead.
add to that is I agree with everything that Dr. Herman said, is that, again, there are some platforms that incorporate this RNA-based testing and others that utilize just DNA. Now, again, most of them are now combined with RNA testing, but that's important because let's say, you have a history that suggests there's going to be a mutation there, and the testing says, oh, there's none there. And if it was just a DNA-based test that was done, that may miss some of these gene fusions that we talked about. And so again, you won't know the answer if it included RNA, but that's where you ask your doctor to say, hey, do you know if this platform utilized the RNA-based testing, or was there enough tissue to do both the DNA and the RNA-based testing? Because sometimes you have to pick one or the other if there wasn't enough tissue. So that's the only circumstance where I would say you might need to either repeat a biopsy or do a different test.
Right, thank
Yes,
you
I
so much.
agree.
Thank you.
I
So we have like really limited time. So I want to maybe get a couple of more questions in. So just to summarize what we just said, if you have a targeted alteration, you were on targeted therapy, then doing molecular testing is important. If your repeat molecular testing is important. If your testing did not include RNA, make sure that you have an RNA. But if we did a testing and you don't have a mutation and you were treated, let's say, with chemoimmunotherapy or immunotherapy or chemo by itself, at this point, there is really no benefit of repeating the molecular testing, because if the first molecular testing was done appropriately, because it's unlikely that you'll develop something. Another question that's coming up, which I think is very good, is how about PDL1? Do we repeat the PDL1 through the series of biopsies, or what's the story there? Dr. Royce, let's me have you answer that question.
Sure. So I guess a few points on that. Number one, there definitely can be variability in the PDL1 test result depending on where you biopsy, in lung versus lymph node versus other sites of disease. It's tough because, again, I don't think we're necessarily going to repeat to look for a difference in PDL1. And I would say it's rare that something is like negative in one biopsy and like 100% in the other. I don't necessarily do repeat biopsies just to assess the difference in PDL1. But I think there's an important point here as well, is that PDL1 is not predictive of immunotherapy benefit for everybody. So, patients who have an EGFR mutation or an ALK alteration or a RET alteration, let's say that PDL1 is high, we know that that's not predictive of immunotherapy benefit in those patients. So, we still get the question, well, if the PDL1 is high and you see an EGFR mutation or an ALK alteration, how do you decide between immunotherapy and targeted therapy? Well, or can you add immunotherapy to targeted therapy? And really the answer in all these patients is there is really no role for immunotherapy outside of a clinical trial or of subsequent certain therapy combinations that I'm sure are going to be covered later on today. So yeah, that's how I would address the PDL1 question.
Okay, wonderful. We are at time. I'd like to thank our wonderful presenters. That was a very robust and very good discussion and very good questions from our audience. So we're going to complete this portion of our presentation and move to the next one. And thank you, Dr. Herman, and thank you, Dr. Royce. And for those patients whose questions we didn't answer, I'll try my best to see if I can add them to the next session. Thank you so much.
Thank you very much.
All right. So next, we have moved to the next session, and it is my distinct pleasure to introduce our next speaker. Dr. Puri, we have already a lot of questions for you from the previous session. So Dr. Sonam Puri is a thoracic medical oncologist from Moffitt Cancer Center who will be discussing understanding targeted therapy. Go ahead, Dr. Puri.
Thanks so much, Dr. Bazhenova, for the introduction. I'm going to be sharing my slides now. Right. So hi everyone. Thanks again for the opportunity for presentation today. I'm Sonam Puri. I'm a thoracic medical oncologist at Moffitt Cancer Center. And what I really want to talk to you about today is something that has really changed how we treat lung cancer over the last decade, which is targeted therapy. My goal is really to make targeted therapy simple, easy to understand. It's biologically complex, but how to really break it down. And so today we're going to be covering what is targeted therapy, how it works, how it compares to other treatments, and most importantly, what it means for our patients and for the loved ones who are on these treatments. So just a practical guidance on what that means to be on targeted therapy. So let's start with really the basics. What is targeted therapy? So we know that every cancer begins with a change in a cell, in the cell's DNA, or in some case the RNA. And we call these changes mutations or alterations. I think this has been extensively covered over the last few sessions. We can think of these mutations or alterations as like a gas pedal, which when it gets stuck in the accelerated phase, it just tells the cancer to keep growing and dividing without stopping. And some of these mutations, because of that mechanism, we call them driver mutations because these are actually the alterations or mutations that are driving the cancer. And that's where targeted therapy comes in. Is Targeted therapy is what, unlike older treatments like chemotherapy, which used to work like a broad net and attack all fast growing cells, including healthy ones, targeted therapy is our precision way of designing a treatment that specifically goes after the driver mutation. So that's what makes it special, and it is unique to the cancer cell. And for the most part, when it's designed, it is designed to leave most of the healthy cells unharmed. So more about targeted therapy. It's important to know that targeted therapy is basically designed to uh, basically have a precision approach for your cancer. The design of these drugs is built to interrupt the specific signals that are sent by driver mutations that tell cancer cells to keep growing. These are cancer focused because we have been able to identify certain driver changes that are specific to cancer cells and sparing healthy cells for the most part. And they are designed to be more cancer specific, less healthy cell toxic, which makes them really the precision treatment. And all of this with an ultimate goal of really making these treatments get you to a better outcome, because the targeted therapy zeroes on the exact change that is driving the cancer. It works for the most part better than traditional treatments. They have higher response rates for many patients, a longer duration of disease control, which makes them a great drug in oncology. I think a very, very important question that is asked is targeted therapy for everyone? When is targeted therapy used? And this is an extremely important question that we should be asking our doctor every time we see them. The answer is that targeted therapy is not always the right answer for everyone. Targeted therapy is most commonly used in a type of cancer known as non-small cell lung cancer. But it's important to know that there are only certain types of cancer in which we can use targeted therapy. And there's another type of lung cancer known as small cell lung cancer, where currently we have no approved biomarker-driven targeted therapies. So when is targeted therapy used? It will be determined by biomarker testing, which definitely has been covered in great detail by Dr. Herman in the last few sessions. So that is the step that helps us determine who gets targeted therapy. Now, the other important question is, how does this targeted therapy work? It works if you have a certain mutation or alteration in your tumor. So what is important is testing, and this is probably the most important part of the talk. I know we have covered how these tests are sent and how these tests are interpreted, but different ways in which your oncologist might be calling these tests is it's biomarker testing or genomic testing or molecular profiling. And it's ideally done for all patients with non-small cell lung cancer before starting any therapy to know if you have the biomarker of interest. And as been discussed, this step is essential because the targeted drug is only going to work if the tumor carries a specific mutation that it was designed to block. It's not going to work otherwise. But what is important is that testing at the time of diagnosis is not the only time that we use. We do biomarker testing and use targeted therapy designed for it. There is also a role of testing when cancer is progressing, and this is done on a case-by-case basis. But especially if your cancer progresses while it's on targeted therapy, your doctor may re-perform either the same or an additional genetic biomarker test to explain why the drug stopped working, to provide a roadmap what to do next. Often we can find more alterations or mutations in those subsequent genetic reports from the tumor that help us provide a roadmap for your next treatment. We can often find drugs that work for those genetic changes that are created at the time of progression. And a very important analogy that I like to use for my patients here is that targeted therapy, it's really like a lock and key mechanism where the mutation is the lock and the drug is the key. So if the lock is there and the key fits, the treatment works. And if the lock is not there, then the key will not work at all. So that's how we look at targeted therapy. Common genetic more mutations or alterations that we see in non-small cell lung cancers that can be targeted. I've just named a few of them here. They've been covered in other talks. We often look for EGFR, which is one of the most common mutations in non-small cell lung cancer. It has several approved drug targets. ALK fusion is found in a subset of non-small cell lung cancer, especially younger non-smoking patients. It's highly treatable and has multiple targeted therapy options approved. ROS1, BRAF mutations are less common, but targeted therapy exists for these as well. And there are other mutations and alterations such as KRAS, MET, and RET, for which there are newer targets, recently approved treatments, and this is also a very rapidly expanding area. But what is important is as targeted therapy has evolved, it is not only looking to improve outcomes of treatment in a way that it's more tolerable, it's more cancer specific, but it is also helping us target areas which were difficult to treat with cancer treatment given orally or IV alone. And this is very, very important aspect of this is that certain targeted therapies that are created are actually able to cross the blood-brain barrier, means that they can reach cancer that has spread to the brain. It's an important advantage that some of these treatments have over traditional treatments that we used to use in the past that didn't used to cross the blood-brain barrier, did not have this efficacy. And why is this important? Because That's often an area where cancer grows, progresses, and radiation is used, which could lead to more undesirable side effects. And definitely one question to ask your doctor is whether the targeted therapy that is being given for your cancer has that capability. Is it protecting your brain? It's going to work in the brain or not? So the next topic that we wanted to discuss is what are the different types of targeted therapies that we use in our clinic right now. And this is a very rapidly expanding area. I'm only going to cover the traditional targeted therapies. Targeted therapies are becoming more and more complex. But the what we call as the original targeted therapies can be broadly divided into two categories. They're called kinase inhibitors or bispecific antibodies, the terms that your doctors often use in clinic. Kinase inhibitors are drugs that block growth signaling protein messengers that tell the cancer to grow and divide. So if there is a genetic alteration or change in your cancer cell that is making it grow and divide, this is like a block on that particular driver. While as bispecific antibodies, they're actually engineered to bind two different targets at the same time, and it often increases the precision and effectiveness of what we are able to achieve just with blocking one treatment, one alteration at a time. How does targeted therapy compare to other treatments that we often hear about? So the first is comparison of targeted therapy with traditional chemotherapy. While targeted therapy focuses on specific cancer cell changes, it only works if your tumor has a matching mutation. It generally has fewer effects on healthy tissue. That often translates to fewer side effects. But the way I think about it and I tell my patients is the side effects are different. Sometimes the side effects could be interpreted as less, but I think they are just different because they don't just cast a heavy net on all your healthy tissues, which chemotherapy typically affects. And while most of the targeted therapies are designed as daily pills that can be taken at home, some of them are still IV, and some of them more recently can be given subcutaneously or injected under the skin. In contrast, traditional chemotherapy attacks all fast-growing cells. That includes cancer cell and healthy cells. It can work regardless of a specific mutation. So traditional chemotherapy works if you have a mutation or don't have a mutation. It's usually given as an IV infusion at an infusion center. And because of its effect on healthy tissue, it can cause more widespread side effects such as hair loss, nausea. And sometimes targeted therapy is given with chemotherapy to make it more powerful. And we use this approach very commonly in a type of lung cancer known with the driver mutation known as EGFR, and it's been shown to be more effective than just giving the targeted therapy alone. And your oncologist is really the one who's going to determine what is going to be the best approach for you when it comes to this combination. How does targeted therapy compare to immunotherapy? While targeted therapy is a direct attack on the cancer, it's like a guided missile. Immunotherapy is an indirect attack. These drugs don't really fight cancer directly. Instead, they release brakes on the immune system, so the immune system can, in fact, recognize the cancer and destroy it, something that immune system does on an everyday basis, but cancer, by oversmarting the immune system, can overcome it, and immunotherapy just releases those brakes. Just wanted to put these three therapies, three broad categories of treatments just on a single slide to point out the differences. But as the treatments are getting more and more complex, we are also building targeted chemotherapies and targeted immunotherapy, which is beyond the scope of our discussion today, but something that is making treatment even more with immunotherapy and chemotherapy even more precise by adding a targeted approach to it. So an important thing is now, what does it mean for you that you are on targeted therapy? And it's important to identify certain unique features about targeted therapy when you're on it, but also certain things that we always have to also keep in mind, just because it's still a treatment that can have um, a lot of complicated side effects. So just wanted to put together some of the questions that my patients often ask me in clinic when I start them on targeted therapy. The most common one is, how do you take it? Most treatments, like I had mentioned before, can be taken through mouth. They come in pills or capsules. They can be taken once or twice a day at home. We usually tell our patients to keep these pills away from other family members for safety. They can actually be given as IV infusion as well, and more recently under the skin at a clinic. And your doctor at the time of prescribing you the treatment is going to go through the specifics of how these treatments are given. It's extremely important that even though these drugs have the flexibility of being given at home, a lot of times monitoring is extremely important, and that can include regular clinic visits, blood draws, scans, because these still can be associated with toxicities, which often can be mitigated if they are identified early on. Another important question that is often asked is, how long will I be taking a targeted therapy? And that's a question that really depends on the stage of cancer that the targeted therapy is developed for. If your cancer has spread beyond the lung, we call it metastatic disease, then you typically will continue the medication for as long as it keeps working. It can be months. We hope it is years, and it is years for a lot of the targeted therapies. In other cases in which we use targeted therapies after surgery to prevent the cancer from coming back, it's called adjuvant therapy. It may be given for a fixed period of time, usually about 2 to 3 years, but your doctor will explain what it would be for your specific situation. Um, an important point about side effects. Yes, targeted therapy, because of it being specific to the cancer, less effect on healthy cells, it has less of the healthy cell side effects that we see with chemotherapy, but it does have a different set of side effects, which are often they can be very serious, and it's very important for us to monitor and educate our patients to be able to identify them and treat them. And specifically, again, going back to the target that I spoke to you about, which was EGFR, very commonly seen. While EGFR is present in lung, it's also present in skin. So a lot of the EGFR targeted therapy agents cause side effects such as rash and diarrhea, and we call them off-tumor on-target effects. And it's important for our patients to know what could be these most common side effects so they can be identified and mitigated appropriately. So certain take-home points for targeted therapy, you definitely ask about biomarkers, genetic testing. It's the essential first step for seeing if targeted therapy is right for you. It is often also the next step when one targeted therapy stops working and we are looking for what to do next. Targeted therapy is precise. It works by blocking a specific genetic change in your cancer, not by attacking the cancer cell and healthy cells like chemotherapy. It's important, even though these treatments have introduced precision, that side effects need to be identified and managed appropriately. And always ask questions. I think that no question is too small about a specific drug and how it works in your cancer. With that, thanks so much for the opportunity to present this again today.
Thank you so much, Dr. Puri, and thank you for staying on time. I know this is a pretty complex discussions. So it is my pleasure to introduce our next speaker, Dr. Suraj Samtani, coming to us from Hospital Felix Bulnes, and he will be talking about cancer nutrition.
I think I'm there. Thanks so much, Dr. Bazhenova. It's really a pleasure to be here. Please confirm me if you can hear me all right.
I can hear you well. I don't
Uh,
see you for some reason, but I can hear you well.
oh, okay. Let's.
Oh, now I can see you.
Oh,
Perfect.
that's it. Thanks so
Fine.
much. It's such a pleasure to be here. Thanks so much, Dr. Bazhenova, for the introduction. And the day of today, I'll be talking about diagnosis and treatment of cancer, cachexia, and lung cancer. I'm a medical oncologist from Santiago, Chile. I work at Clínica Las Condes and Hospital Félix Bulnes, and also the medical director of an oncology program here in Santiago, Chile. Thanks so much for the invitation, and hopefully this helps a lot of patients. So, basically, first, the unignorable numbers. Lung cancer remains the main cause of lung cancer mortality in the United States and worldwide, 236 new cases. And we have advanced a lot in specific treatments and personalization of treatments, as we're going to talk during the whole day of today. But we also have a 20% overall survival at stage 4. But the one of the biggest amount of numbers is that we have 70% of presence of cachexia in our lung cancer patients, which is a high prevalence of this diagnosis. So, what's the definition of cachexia and how do we recognize the signs and symptoms of cachexia? So, cancer cachexia is usually confused with weight loss, but these are two different entities. It's a common but under-recognized cancer complication and has a major impact on treatment tolerance and outcomes. So, early recognition is very, very important because we have different types of treatments which we can provide for our patients for them to better tolerate our treatments, and when we tolerate better our treatments we get better response in terms of our lung cancer. So what's the pathophysiology of this? So there are different mechanisms which explain cachexia in lung cancer. It's not the fault of the patient, but it is part of the diagnosis. It's part of the tumor and it's part of cancer. And this is due to the persistent systemic inflammation driven by elevated biomarkers like interleukin 6, transforming growing factor, and growing differentiating factor 15, which is a new factor which has been studied as a inflammatory mediator and which has been proposed as a target therapy, as we're going to discuss in this presentation. So this follows a dysregulation of appetite control and whole body energy homeostasis. So what happens in our patient is that there is an accelerator skeletal muscle catabolism with reduced protein synthesis, and there's also an impaired insulin sensitivity. So this explains a systemic inflammation in our patient with a metabolic dysregulation, and this is the presence of cancer cachexia in our patients. So this is as we mentioned before, this is an explanation in terms of systemic inflammation, which will consequence in anorexia, muscle atrophy, impairment of different metabolism of different drugs also, and this cannot be reversed only by nutritional support alone. So you distinguish this diagnosis from malnutrition because we need a multidisciplinary team to be able to provide the best care for our patients. So what's the prevalence of cachexia? It goes between 60 to 80%. And it's only not present in lung cancer patients, but it's also present in pancreas cancer patients, in upper GI cancer patients, and also in a 50% approximately of cancer patients, between a 50 to 70%. So this is a very frequent diagnosis for our patients, and it should be one of our priorities in the treatment during our the chronic disease of our patients with lung cancer. And we have studied in Latin America and the US also. This was a trial we published in which we studied the role of cachexia grading systems in patients with non-lung cancer and implications for survival. It basically differentiated in 4 groups of patients according to their index or their BMI and the percentage of weight loss. And this was categorized in 4 categories. And which were our results? The trial demonstrated that patients classified as low risk had significantly longer overall survival compared to patients with intermediate or high risk. Cachexia was an independent association with worse overall survival in patients with lung cancer treated with immunotherapy. So, independent of the treatment, patients who had cachexia lived less time compared to their counter patients group who had treatment during their period of time. So, which are our diagnostic tools to assess and measure cachexia? This is an evolving field, so it's very, very interesting as we have more patients who develop chronic disease, which we have better treatments in target therapy and immunotherapy. We also have to implement better tools to diagnose and to measure cachexia throughout our patient. So we have to understand cachexia has different progression stages. We have pre-cachexia, which is early metabolic changes with mild weight loss of less than 5%. We have cachexia itself, which is the clinical syndrome with more of 5% unintentional weight loss. And we also have refractory cachexia, which is an advanced disease and it's unresponsive to intervention. So, which are our hallmarks? And this is a very important. This is evolving, so it's most probably going to change in the future years. But it's not only weight loss. Weight loss is one of the diagnostic criteria, but we also have anorexia and early satiety, profound fatigue and weakness, and we don't have one specific test that will tell us this patient is under pre-cachexia or cachexia, but there are certain markers of systemic inflammation like CRP or albumin, which could provide us the tools to be able to diagnose at an initial stage and to be able to make a correct follow-up in our patients. There are certain tools. We have MST, which is malnutrition screening tool, NRS 2002, but those are all in terms of weight loss principally, but there is a comprehensive mini Casco tool, which is evaluating a multidisciplinary score based on nutritional status, inflammation markers, functional capacity, and other parameters that we're going to discuss. So as we mentioned before, cachexia is also an evolving field in the terms of our patient. Usually our patients which are in advanced stage are in cachexia or refractory cachexia, but usually patients who are in an early stage, we can detect them in pre-cachexia, and targeting different multidisciplinary approaches can make our patient tolerate treatments better. Which are early signs of cancer cachexia, aside from weight loss, is decline in the hand grip strength. So that's why physical therapy is so important as an initial evaluation for our patient. Reduced physical performance, fatigue disproportionate to the tumor burden that we're seeing in our patient, and also the laboratory test of different biomarkers as CRP, albumin, which are biomarkers that we, as doctors, usually take into account as an initial assessment for our patients. What's the impact? As we mentioned before, it reduces the treatment tolerance. It increases the toxicity and dose reductions. It reduces the physical function and autonomy of our patients. It reduces the quality of life. And as I mentioned, it also has an impact on overall survival. So the first part of this presentation was to differentiate cachexia from malnutrition, cachexia from sarcopenia, and cachexia from frailty. It's a multidisciplinary diagnosis which involves more than one a clinical aspect of our patient. And it varies from patient to patient. It's very different from a pancreatic to a breast cancer to a lung cancer. It's very different. And today we're going to focus principally on lung cancer patients. So the unmet needs says that it's basically underdiagnosed and misdiagnosed. There's no standardized diagnosed pathway. There's guidelines of ASCO, ESMO, and different entities. Approved therapies are ongoing on different trials that we're going to revise during the presentation. And there is also limited and inequitable access to trials. For example, in South America, we still don't have access to cachexia trials, which is something very important for our patients also. So as the first part, the first takeaways, we have to identify patients at risk. We have to identify them early. We have to monitor relevant treatment outcomes. We have to improve our assessment tools. We have to make an optimal management for our patient and monitor outcomes in a strategic way with a multidisciplinary team. So, which are the strategies to improve the appetite, the lean body mass, and the physical function in patients with cachexia? So, the first thing is the importance of the diagnosis and to have proper screening tools in each of our centers in which all of our team are have the instruction to be able to provide the best care for our patients according to the tools that we think is the best one to our multidisciplinary team. So in terms of functional and body composition assessment, we can use tools as physical function assessment like the hand grip strength measurement, the 6-minute walk test, and performance status evaluation. In terms of body composition, there have been different trials evaluating CT imaging and dual energy X-ray absorptiometry, which could tell us how that patient is really tolerate or the proportion between the muscle and the other qualities of the body of our patient. And also key diagnostic results as the loss of weight in certain period of time, like 5% in 6 months, or even less amount, but also in a shorter period of time during treatment. So it's not only body weight, but it's also including other variables to be able to give us the best information for our patient. So how should we do it? Or how should patient maybe ask their different certain teams and different centers? Usually we should screen our patient maybe hopefully at every visit or every 2 visits. We should diagnose as an initial status and assess and implement a multimodal treatment from the first visit of our patient and then monitor and adjust throughout the treatment. Also, it's very important to tell our patient that it's not the fault of the patient, but it's part of their tumor, it's part of their disease, because it's how many patients we see in our private clinic or in our clinic in which they say they really want to eat more, or they really feel like they really can't satisfy the needs of what the rest of the team can be. And this is not because the patient really can't do it, but it's part of their disease, especially at the beginning of the disease before we start the treatment. So one emerging tool which I like a lot is this mini Casco, which evaluates weight trajectory, inflammation markers, nutritional status, functional capacity, and quality of life parameters, which gives us a full of how our patient is behaving at the initial of the diagnosis and how the patient can evolve to uh, to be able to implement different tools to be able for our patient to have a better quality of life during the treatment that we're going to provide. So, under the clinical challenges and management approach, remember that we have to recognize this diagnosis and also the importance of early detection with enables metabolic and nutritional stabilization before irreversible muscle loss occur, changing the disease trajectory and allowing the maintenance of functional independence. Which are the barriers for us as doctors? Time constraints, maybe weight loss normalization, fragmented workflows. So here's where our team has to be super, do we have to work together in terms of systematic screening, multidisciplinary approach, embedded tools in our teams, and education for our patients. So that's why I'm so happy about Grace having this presentation the day of today for our patients. So what's the importance of multimodal therapy? Here is the key of the presentation. We can't do it alone. We need a multidisciplinary team involvement. We need nutritional support. We need supportive care. We need physical therapy, and we need psycho-oncology also as tools at the beginning of the treatment for every patient. And improved management of cancer requires a multidisciplinary approach, but treatment is best commenced earlier rather than later. What does the guidelines tell us about it? ESMO and ASCO integrates oncology integrated multimodal care, and of course, a practical and patient trajectory focus. This has to be personalized immunotherapy and target therapy. This also has to be personalized according to each of every of our patients. In terms of guidelines, this is very important that there's not a guideline that we can tell for all of our patients, this is the perfect prescription. It doesn't work like that. We really have to personalize in terms of nutritional supplement. It's not my super area of interest to tell you the perfect prescription, but yeah, there are certain guidelines that tell us that a patient should consume between 25 to 30 kilocalories per kilo per day with an intake of protein of up to 1.5 grams per kilo per day. We have to understand that nutrition is best by normal nutrition and natural nutrition. Supplements can help us to provide the intake of our patient, but it doesn't make that our patient can only be under supplements with not normal nutrition on our daily basis. That's very important for our patients to also understand. In terms of the guidelines of exercise, each year we know that strong endorsement of exercise is a core therapy. It shouldn't be, if a patient wants to do exercise, it should be part of treatment. Exercise is part of treatment, and we know at the day of today that it improves the overall survival of our patient and improves the tolerance of treatment. This was a trial we did in our local clinic here in Chile. We presented a poster at ASCO last year in which we demonstrated early functional assessment, significant improvements in physical impairments in our oncological patients. And we really demonstrated how oncological patients in a personalized treatment improved their tolerance to treatment. They had less fatigue, they had less digestive symptoms, they slept better, and also they improved and the tolerance to treatment, which allowed us to give more treatments to our patient. And when we give more treatment to our patients, we have a better overall survival. The evidence not only in lung cancer, it's also in colon cancer, as a huge trial published in the New England Journal of Medicine last year, in which it demonstrated a landmark demonstrating exercise intervention improves outcomes in colorectal cancer. And also we have trials in other cancer. The important thing of exercise is, was before we used to think that slight exercise used to be effective. As of today, we know that the more intensive the exercise is, the better. And this is very, very important because usually patients can go to a gym in which there is a physical therapy which doesn't have all the information about oncological patients. So that's why the more personalized is the team in oncological patients, the better. As of today, the more intense is the exercise, the better is for our patients in terms to reduce the fatigue, to improve survival, and enhance quality of life. So it's super important that guidelines in real life practice are sometimes not effective because there's lack of application of guidelines in real life, and nutritional and exercise interventions are not appropriately used. So this is something that we have to think of improving in all of our centers worldwide and make it part of treatment as the patient is diagnosed with lung cancer. In terms of late identification, as we mentioned before, the early, the better. The reality is that cachexia is often recognized only in advanced or refractory stages. Why? Because weight loss was normalized as expected, or it was the only diagnosis. But we know now that it has a multidisciplinary approach with different tools, which allows us to get a better diagnosed treatment. The impact is nutrition and exercise are introduced too late to be effective. We have to introduce it sooner for our patients to get the benefits of this treatment. So I think this slide resumes what we have been mentioning during the presentation. It doesn't just need a medical oncologist. We need physiotherapists, we need nutrition, we need nurses, a multidisciplinary team that allows us to provide the best care for our patient in terms of counseling, which remains central to be able to improve the outcomes for our patient in terms of overall survival, but also quality of life. In terms of summaries, nutritional intervention is very important. High protein intake combined with certain supplementation. Clinical trials are evaluating novel strategies and multimodal intervention protocols with individualized exercise therapy programs, combining resistant training and aerobic exercise. This is very important. Aerobic exercise has shown to reduce the inflammation markers, which were higher in our cachexia patients. So this is very, very important. And pharmacological support, which I'll be talking on the next few slides. So which are the guidelines and which are the novel therapies on the horizon for cancer cachexia? As I mentioned before, the management has to be personalized. Usually is dietary counseling. Many patients approach us to receive enteral feeding tubes or parenteral nutrition, which should not be routinely used. We should try to use our natural body to be able to get the best results possible. And In terms of drugs which could help us, there's this trial of olanzapine in advanced GI and lung cancer. It was a randomized, double-blind, placebo-controlled trial with patients over 18 years old. The primary endpoints was weight gain, and secondary endpoints was change in nutritional status and quality of life. And they were randomized to olanzapine plus chemotherapy versus placebo plus chemotherapy. And they had positive results in terms of patients gaining more than 5%, which was their primary endpoint. There are different pharmacological approaches and targets in clinical trials. We have, in this case, anamorelin, which is a ghrelin agonist. We have espindolol, which is also another drug which has been in trials. And as of today, a GDF15 antagonist like ponsegromab is really evolving in this field. This is the effect of anamorelin on lean body mass. We see that there were two phase 3, Romano 1 and 2 trials with significantly increased lean body mass, body weight, and anorexia in our patient compared to placebo, but it didn't result in significant changes in hand grip strength. So it's very important to know which is the part of or what is the objective that I'm looking with my patient, and let the patient be part of the treatment also in terms of knowing what's the outcomes we are trying to proceed with our medications. There's also this phase 2 trial of espindolol in lung cancer patients, and we did see that key results of 10 milligrams of high dose espindolol reversal the weight loss, improves the body mass improvement, and there's numerical improvement of fat mass also in our patients. The phase 3 of espindolol in patients is planned, and it should be ongoing in the near future. As we mentioned, this is an evolving field. We're trying to personalize treatment as we do personalized target therapy and immunotherapy in our patients based on biomarkers and NGS. And there is where we had to do a trial first to know which was the cytokines or the inflammation that was taking a higher role in our patient. And this trial went to look at the association between weight loss and cytokines in patients with lung cancer. And what we can see here is GDP, which is growing differentiation factor 15, was associated with patients in with had weight loss and as a cytokine that could explain the factor that could be explaining why these patients have weight loss through their treatment and muscle weakness. So ponsegromab is trying to be able to help us fix this problem in our patients. It's an antibody which specifically targets GD15 pathway, and blocking the GD15 pathway malabsorption could help us in improving appetite, improving body weight, physical activity, and muscle function. We're eagerly waiting for the results of these trials, and most probably it's going to be another tool to be able to help us, our patient, to tolerate treatment in a better way. We do have certain data of the preclinical trials and the phase 2 trials, which effectively was giving us a positive change in our patients in terms of compared to placebo, which this was performed, as you can see here. We evaluated the weight change at week 12, and we can see how the results were positives in our lung cancer patients. There's an evolving field, and we should evolve also as we evolve in so many different trials that we've been discussing today, in so many personalized treatment and different treatments that we're going to be providing for our patient to improve overall survival outcomes. There's all the trials that are ongoing in terms of pharmacological treatments. And I know that as of this presentation, most probably next year, we're going to be talking even about more drugs, but also talk about best option to improve the quality of life for our patient during this amazing treatments that we're providing in terms to improve our overall survival. I wanted to just highlight this slide once again as a multidisciplinary approach, how this should be the counseling of our patients at the initial stage, not as a later stage, and all of our patients should go through a multidisciplinary team at the time of the diagnosis. Thanks so much. This is my contact for any other questions that you would like to ask me, and I'm very eagerly excited for the Q&A of today.
Thank you so much. Okay, so we have a Q&A until until 10:05. So we have about 15 minutes of questions left. So do I have Dr. Puri back online? Hi, Hi, Dr. Puri. Okay, so the first question that I'm gonna ask Dr. Puri. So one questions that come in is, you've talked about targeted therapies and how it's different from chemotherapy. How do we know that the targeted therapy is actually working? What can we use to establish the efficacy of targeted therapy for each specific patient? And if you can touch upon the following question as well, when the patient progresses from targeted therapy, what type of progressions can we see, like systemic, oligoprogression, CNS progression, and does it matter for you as a treating physician the type of the progression the patient has?
Yeah, great questions. So targeted therapy, we know that because of the precision approach, can actually work faster than traditional treatment. So often the way to assess response is to see, first of all, see if there were any symptoms associated with cancer. A lot of our patients actually notice that the symptoms actually start to fade away within a few days to weeks of starting targeted therapy, and there could be an enlarged lymph node which they can feel is going down. It can be a cough that's getting better, pain that's getting better. Those are all clinical ways of knowing that you're responding to targeted therapy. And then, as physicians, we do scans typically 6 to 8 weeks after we start treatment. All the body parts of the body that were involved with cancer should be included in that scan. If there was cancer in the brain that we were not treating with radiation and we were only treating with targeted therapy, that should be part, MRI brain should be part of that scan. Otherwise, scanning of the entire body in usually a 6 to 8 week period after starting therapy. Those are the ways in which we assess response. Um, Sometimes just blood tests alone don't help us guide to a response unless the cancer was damaging any part of the body like liver, and we knew that the damage that we're seeing in the liver is because of the cancer. We can even see improvement in those labs, but labs or blood tests for the most part don't guide us alone. It's usually clinical symptoms and scans. So that's how we assess response. Now, as far as the pattern of cancer growth on targeted therapy, we see often that the cancer could just grow in one or two areas when it starts to grow out of treatment on targeted therapy. And we call it in the scientific term, we call it oligoprogression. That basically means that there are less than 5 sites that have started growing. And why is that important? Because there's been data that has been shown that if we can actually just target the areas that are growing with local treatments such as radiation, then we can even continue the targeted therapy for a longer time rather than changing. It's really a clinical decision between you and your oncologist at that point. It depends on the amount of time that it took to have that cancer growth, the speed of growth, what kind of symptoms you're having to decide whether just treating it with radiation and continuing treatment is the right approach, if it can even be radiated. But that's certainly a strategy that can be used with targeted therapy.
Thank you so much. So the next question I'm gonna have is for Dr. Samtani. So cancer cachexia and difficulties with appetite and difficulties with maintaining food uptake is actually quite common in our patients with lung cancer. So what if you have a patient who, let's say, started a new regimen, and let's just mention docetaxel, which is a common chemotherapy we use, and this makes the appetite worse, makes the patient have mucositis, changes the taste perception. Should we stop treatment or can we do something to improve the nutritional based symptoms and then continue still on chemotherapy?
So I think that's an excellent question, Dr. Bazhenova, and I would like to hear the whole panel also on this. So basically, docetaxel is a chemotherapy we use in lung cancer, second line, and And we have to understand that when a cancer is progressing, usually, or it's advancing, the initial status will give us symptoms of the cancer always. And the initial process of our patient is always difficult. And docetaxel, as starting the chemotherapy, is going to give us adverse effects of the first chemotherapy. So if we think in a positive way, docetaxel will allow us to reduce the volume of disease, and hopefully the symptoms of the tumor will start reducing and we'll only have the adverse effects of chemotherapy. So how do we balance all of this in terms of giving the best care for our patient? In terms of nutrition, as I mentioned, there's no magic prescription for all of our patients, but we do use certain or we do use certain tools. For example, we try to give food more times during the day with lesser quantity to be able for our patient to tolerate it better. We don't look for a certain amount, but we do look for a balanced nutrition, and that's why the nutrition counseling is so important at the beginning. Using medications which can help us reduce the symptoms and maybe increase the appetite is also an alternative, as we mentioned in the presentation. And also, we can also, we think as medical oncologists, we also think of adjusting the dose in terms of the adverse effects, which can also help our patient tolerate it better. Especially with target therapy, for example, in this case, chemotherapy, we know that by adjusting the dose, we have better quality of life. We maintain our overall survival in terms of how much our patient is responding throughout time. So that's also a very good approach, especially at the beginning when our patient is experimenting these two sides of symptoms, which is the tumor, which is increasing with a high volume, generating the symptoms, and also the adverse effect of our patient. I usually tell my patients that at the beginning is like the most difficult period of time because we have these two factors, which is very difficult to differentiate which is generating what. And as soon as we control one of them, usually our route to our objective becomes an easier route for our patients who also have a lot of adverse effect.
Thank you so much. Dr. Puri, the next we have kind of three questions which are very similar. So I'll post them to you. So the questions basically stem from the fact of who needs targeted therapy? How do I know that we need targeted therapy? And I'm going to post the question verbatim, but then if you can just highlight like the whole explanation of who needs target therapy. So let's say when patient stage 4 feels better, and after 3 months of chemotherapy, PET is clear, does he still need targeted therapy? So I know there is not enough information in that question, but if you can just explain it again, who needs target therapy? When do we need target therapy? At the time of the diagnosis, when do we say, not really safe, but push it to the second line? How are those decisions being made?
Yeah, so I think what is central around targeted therapy is that it's again like kind of going into the key and lock model is that targeted therapy only works if we have been able to identify a genetic change, which is could be a mutation and alteration in your tumor that we have a specific target for. Basically, we have a drug designed for that genetic change. Now, most commonly, we test for that genetic change before starting treatment so that we have all the information available about the tumor before we are designing the first treatment for cancer. So targeted therapy is the right for most of the targeted therapies that are available. Targeted therapy is the right answer for first treatment, except for a few targets that have been identified. We've developed drugs for it, but they have not yet proven that they're as effective as non-targeted therapies when given as the first treatment. And often for those cancers, targeted therapy is given as the next treatment. So I think just to kind of maybe make it like simple is targeted therapy is the right treatment if your cancer has the lock for it, the key, it's a key for a lock that has to be present in the cancer. And for the most part, it is the right answer for your first treatment, but it could be the right answer for your second treatment if it has not been identified to be as effective as the first treatment, which is non-targeted. Did I answer that question appropriately, Luda?
Yeah, thank you. Another question that it was actually left from the first session. We didn't have time to answer, but maybe I'll pitch it to you as well. So on the molecular testing, sometimes you see a mutation P53. This is a very common mutation, but as of now, I know we have drugs in development, but we don't have any approved medicines for that mutation. What does P53 means for you, and do you change your treatment based on that mutation?
So that's a great question. P53 is actually one of the most commonly or common alteration that we see in tumors and across the board, not only for lung cancer but for all types of cancers. And as been mentioned, it is an area of active research right now, but there has really not been a drug that has been developed to target T53 individually. What we do know is that it does impact what we call as prognosis, or it does predict sometimes the response you're going to get with other treatments. And this is particularly true when TP53 mutation is present alongside some other driver mutations such as EGFR or ALK, when we know that presence of T53 with those mutation makes the existing drugs work less. And that sometimes we think about, if that is present, how do we make the treatment stronger than just the treatment that we are giving? But that's where it is applicable right now on designing treatment. It doesn't have its own treatment by itself.
Thank you so much.
Uh,
Dr.
right.
Samtani, commonly we are faced with the patients who come into us already underweight because of the cancer diagnosis or because of the other conditions. And let's say I know I'm going to give treatment that will decrease appetite, will decrease taste perception, and maybe even worse, can cause mucositis where the eating will become more challenging. How do you guide those patients and their families on the nutrition that they need to do while going through the cancer treatment? Is there a tips and tricks you have under your sleeve that can help this patient maintain appropriate nutrition?
Well, I think that's a great point, and I think we can always divide it if it's target therapy, immunotherapy, or chemotherapy, right? We do know there are different types of side effects. So the initial assessment is always very, very important for our patients, and sometimes considering a pre-rehabilitation for our patient in terms of it's not exact, but in terms of 2 weeks for our patient, because usually we are very eager to start treatment, and I think me as a medical oncologist, I'm very eager to start treatment to be able to provide control for the tumor. But we also have to think that when patients are advanced, this is a chronic disease in which my treatment is going to be a long period of time. It's not going to be for a short period of time. So to have my patient to be able to tolerate this long period of time, I would like to have him in the best possible status as of an initial. So, considering a pre-rehabilitation of physical therapy and nutritional therapy for the first 2 weeks, it's a very good way of starting. I know we all become anxious, and also the patients who's in front of us becomes anxious because they want to start as soon as possible. But we do know that pre-rehabilitation for our patients before the start of treatment gives us a patient which will be able to tolerate treatment on a longer period of time. Second, to be having evaluation on short periods of time. What do I mention? Usually, at the beginning of my practice, the nutritionist used to see the patient at the beginning, after 3 months, and after 6 months. What do we do now in the clinic? Every 2 weeks or every 1 month, the patient should be having nutritionals because each patient tolerates a combination in a different way. We have learned that with our patients, and that's very, very important. Third, interaction of medications and supplements. For example, lorlatinib, which you use it in ALK, has a lot of interaction with certain food or other ALK inhibitors, like, for example, alectinib. And that's very important because each treatment should should provide an assessment of a nutritionist to be able to downregulate that interaction for the medication to be more effective, because sometimes we increase the levels of cytoplasmatic drugs and that increases the adverse effect of our patients. That happens with alectinib, lorlatinib, and also with other EGFR inhibitors. And those in those ways we can provide a better care for our patients. Usually, a lot of patients ask us about admission for feeding tubes or parenteral nutrition. We don't suggest that as an initial approach. We try to have our patient as in their home with this multidisciplinary approach, and in most of our patients, we can provide a very good care for them.
Thank you so much. All right, I have a task of keeping everybody on time, and I think we succeeded for this first part of our webinar. I'd like to thank my faculty members and thank Grace team for organizing the first part. So the second part of the webinar will start at 10:40 Pacific time. So if you can just correct it to where you are in a time zone. And then the second part of the webinar will go specifically through each targeted alteration and explain to everybody what is the best treatment for each targeted alterations with specific recommendations for each. So again, thank you everybody for joining me today and joining Grace team today. So take about half an hour break, and we will see those of you who are interested to continue with our webinar back on the same Zoom link at 10:40 a.m. So which is about half an hour from now. Thank you very much.
Thank you.
Thanks so much.
Good afternoon, everybody, and welcome back to the second portion of our webinar. I hope you're now caffeinated and fed and ready to listen to the second part of our session. For those of you who missed the first part of the webinar, where we were going through some basic information about targeted therapy, biomarker testing, how to read the molecular testing report, this will be available on Grace's website for you to look back. Before we start, this event would not have been possible without our sponsors. So I'd like to thank Genentech, Bristol Myers Squibb, Lilly, Takeda, Janssen, Daiichi Sankyo, Foundation Medicine, and Bayer. It is my pleasure to introduce our first speaker, but before I do that, I want to make sure I explain how the webinar is going to go. So we're going to have two presentations on each on a specific target, and we're going to keep a Q&A session until after those presentations have completed. So now back to our speaker. Again, it's my pleasure to introduce Dr. Tejas Patil, who is an assistant professor of thoracic oncology at the University of Colorado Cancer Center. Welcome, Dr. Patil.
Thank you. Thanks for the kind introduction, and thanks to the organizers for inviting me to present for this talk. I'm going to share my screen. Just give me a moment. All right. So I'm going to focus on EGFR and HER2 alterations, and a portion of my talk will overlap with some of the content that has been previously discussed. These are my disclosures, and these are my objectives. So we'll do a background just to get some table setting. We will cover biomarker and targeted therapy, and then we'll spend the majority of this discussion on EGFR and HER2 mutations in lung cancer, and we'll conclude with a little talk on the impact of timely biomarker testing. So this is a well-known slide. I'm citing a lot of the risk factors for lung cancer that are known to many in the audience, but it's worth putting this in a concise form. By far and away, the largest modifiable risk factor for lung cancer is tobacco smoking. And this diagram here was really wonderful in showing the variety of carcinogens that are in a cigarette. And also documenting where in the cigarette themselves you would find these carcinogens. There's also environmental tobacco smoke, biomass burning, especially in populations from countries where burning cow dung is commonly done, is a very big global risk factor for lung cancer. Air pollution has become more and more a concern. And then within the United States, and especially in the state of Colorado, high levels of radon exposure, especially in basements, are a high concern. From a biological standpoint, there are certain genetic predispositions to lung cancer, specifically de novo T790M mutations. Solid organ transplantation carries a lifelong risk for lung cancer, and then a variety of other cancer risk factors shown here. The one I want to mention is something called the field cancerization effect. So a prior history of lung cancer dramatically increases the risk for a subsequent lung cancer, and I think that's sometimes underappreciated. This is SEER data, and this shows the incidence of cancer diagnoses on the top and the estimated deaths from cancers on the bottom, divided by sex. As we can see, lung cancer is still by far and away the most common cause of cancer-related mortality in 2024. And I will update these in subsequent talks, but even in 2026, this unfortunately still holds true. So I want to talk a little bit about chemotherapy as a way to sort of ground the conversation of why we're going to talk about targeted therapy. When we think about chemotherapy options for lung cancer, we generally break them down into treatment options for small cell lung cancer, which I won't talk about, and non-small cell lung cancer, which these are shown here. This is one of the most succinct and depressing slides. And what you're seeing here is a Kaplan-Meier curve showing the probability of survival after a diagnosis of lung cancer with supportive care versus supportive care and chemotherapy alone. And I think the key take-home message is that chemotherapy on its own, while it does have a role in lung cancer, has only improved 1 year overall survival by 29% versus 20%, which is just best supportive care. So why has lung cancer mortality and improvements in lung cancer been so inspiring in the last 20 years? And I think there's 3 things that drive this. The first is improvements in lung cancer screening. The second is the discovery of biomarkers and the use of targeted therapies for lung cancer. And third is the use of immunotherapy for lung cancer. Collectively, these 3 advances have moved the needle considerably. I will be focusing on biomarkers, and I want to start with this idea of what is an oncogene addiction. You might hear your doctors use this phrase, and what it's really trying to convey is a simple concept. This is the reliance of tumor cells on a single activated protein or pathway to sustain a malignant phenotype. And to sort of say that in different words, there can be many mutations in a cancer, but there seems to be one dominant pathway that's driving the cancer to grow. And we can take advantage of this dominant pathway by developing drugs that block it. And so there are ways to block it from the outside of the cell surface. We call these monoclonal antibodies. And there are ways to block it from the intracellular side of the pathway. That's called tyrosine kinase inhibitors, or TKIs. Now, when we think about mutations, I like this slide because it conveys a lot of different types of mutations using linguistics, which is a little bit easier to understand. We can have mutations that fundamentally don't change the structure of the amino acid sequence, or in this case, on the left-hand column, the meaning of the sentence. So if we substitute a C for a K and say the cat ate the rat, the meaning of the sentence still is the same. However, we can start to mess around with substitutions or deletions or insertions, and you can start to see that the meaning radically changes based on the type of change that's used. So, for example, if we insert an H instead of a C and we say the hat ate the rat, we have a very different sentence. And a canonical example of this is a KRAS G12C mutation. The glycine, the G, is being substituted with the cysteine, the C. We have all sorts of other mutations. We can have frame shift deletions. The best example of this is an EGFR exon 19 deletion. We can have frame shift insertions. The best example of this is EGFR exon 20 insertions. We can have translocations. So here, one genetic sequence in a chromosome gets swapped with another. They come in close proximity to each other, and they produce this new hybrid protein that doesn't exist. The best example here is EML4-ALK. We can have repetitive gene sequences. This is very well described in breast cancer, or ERB2 or HER2 amplification. And we do see this a little bit in lung cancer as well. And then finally, you can just have a very unstable chromosome with multiple gene copy numbers. And this is actually best illustrated in things like trisomy 8 for AML and MDS. This is a pie chart looking at the distribution of mutations or oncogenes, which we talked about in a previous slide, in lung cancer. And I want to summarize this slide by saying that about 45% of mutations as of 2026 can either be targeted with small molecule tyrosine kinase inhibitors or monoclonal antibodies, of which EGFR mutations account for about 30% and HER2 alterations account for 5%. So I want to go back to that Sears statistics that I showed you earlier. And I just want to do some math with you. If you add up the number of cases of lung cancer annually, this is from 2024, we get 234,580 cases of lung cancer. Now, not all of these are going to be non-small cell lung cancer. There's a portion of this that will be small cell. So let's take those out. And we have 197,047 cases. So if you grant my assumption that 45% of these will be oncogene driven, that leaves us with 88,671 cases of oncogene driven non-small cell lung cancer. And the reason I'm mentioning this is that sum total is higher than the annual incidence of pancreas cancer, which we think of as a very common cancer subtype. This is all to say that oncogene driven lung cancer is actually very common. So why do we care about targeted therapy? I'm going to show you two graphs here, and I'm not going to spend too much time on describing these trials. The one is on the left is from the IPASS study. The one on the right is a Korean retrospective series. But the main take-home message here is that when you identify an appropriate biomarker in a patient with lung cancer, and then you give the matched appropriate targeted therapy, you see improvements in overall survival and progression-free survival. The diagram on the right is particularly interesting because this is a 10-year study out of Korea looking at the rates of survival for lung cancer based from 2010 to 2015, and then from 2016 to 2020. And the big thing that changed in Korea during this period was the adoption of more widespread molecular next generation sequence testing. And you can see that there's been a stage migration, meaning patients have, not stage migration, rather, a shift in survival per stage for each stage that's listed. That's 1, 2, 3, and 4. This is a nice quality of life analysis looking at how patients report quality of life with targeted therapies. And no surprise, if you give a patient a targeted therapy, in general, that's going to have a higher quality of life index than, in this case, this was carboplatin and gemcitabine, a two-drug combination for chemotherapy. Now, just because you're getting a pill doesn't mean it doesn't have side effects. And this is a nice diagram that summarizes the variety of side effects that we can, that treatments can cause depending on where in the pathway we target. And for the purposes of this talk, we're really just going to focus on EGFR and HER2. So EGFR therapies have come a long way. First generation drugs like gefitinib and erlotinib were discovered shortly after 2004. We had second generation drugs in 2013 with afatinib and dacomitinib, and more recently we have third generation drugs like osimertinib and lazertinib. I didn't plan this, but I just thought it was very interesting that all of these drugs seem to correlate with the release of Bond movies. So if you can remember that, then you can remember the generation of the drugs. In terms of side effects, I think this is what we're really concerned about in clinic. So the E in EGFR stands for epidermis, which is skin, and skin side effects are a major problem with this class of drugs to varying degrees. Osimertinib a little bit less so than second generation drugs like afatinib. We can also see drying of the skin, and when you get drying of the skin, you can get these very painful fissures and cuts that you're seeing here on the right-hand side. Additionally, the epidermis also includes the gastrointestinal tract, and so we can see things like oral ulcers and diarrhea to varying degrees. This is a class set of effects, and what I mean by that is any drug that targets EGFR will to some degree have these side effects. Now, moving into more recent data, I talked about osimertinib being the most recent drug. It turns out there's actually newer data looking at combination therapies for patients with EGFR mutant lung cancer. I've shown a diagram here. This is a Kaplan-Meier curve from the FLAURA2 study, which looks at osimertinib plus chemotherapy compared to osimertinib alone. And what I want to highlight here is that the combination of upfront chemotherapy with osimertinib improves the median overall survival by 47.5 months in relation to osimertinib, which is 37.6 months. And this has effectively become the standard of care for a lot of oncologists in the United States. Now, there's still a role for osimertinib by itself, and we can certainly have a conversation about that in the discussion. But I think for most oncologists, if the patient is fit and able to receive this combination, this is one strategy. Another strategy is a chemo-sparing strategy using a drug combination called amivantamab and lazertinib. This too was also shown to have an overall survival benefit. And I think certainly we can have a conversation in the panel about how we think about sequencing these. When would we use the amivantamab and lazertinib? When would we do osimertinib plus chemotherapy? Who should we not give this to? I think these are great questions and something that I have continued conversations with my colleagues in the field. I want to make a brief note about something called non-sensitizing EGFR mutations. So the majority of EGFR mutations are going to be EGFR exon 19 deletions or an exon 21 deletion called exon 21 point mutation called L858R. However, there's a variety of other mutations that can show up, such as G719 or E709. We call these non-sensitizing, or sometimes you might hear the word atypical EGFR mutations. And I think the optimal strategy for these continues to evolve. A lot of us will use drugs like afatinib, although osimertinib is also an acceptable alternative. I think there is emerging data that maybe we should rethink our classification systems based on something called the PAC classification system. I'm not going to get into that for the purposes of this talk, but I think this is an area of research that is constantly evolving. I want to pivot to HER2 now, and I first want to start by saying that in many ways, HER2 is very similar to EGFR. They're both members of what's called the ERB family. EGFR is ERB1, HER2 is ERB2. And in lung cancer, there are two ways to target this. One is using a drug called an antibody drug conjugate, and I'll talk a little bit about what that is. But the drug here is TDXD. This is based on the DESTINY-Lung02 data. This targets the HER2 pathway from the outside of the cell, so it's a cell surface targeting treatment. We have newer drugs like zongertinib and cevabertinib that are available for patients with HER2 mutant non-small cell lung cancer that target the pathway from the inside of the cell, what we call the intracellular domain. So I'm going to start with zongertinib. This is the intracellular targeted therapy. And when we think about side effects from zongertinib, one thing I want to draw your attention to is that many of these seem to be very similar to the side effects we see with EGFR mutant non-small cell lung cancer. So we see things like diarrhea, we see things like rash. These are presumably what we call off-target, meaning this was not the intended target of attack, but is sort of what's happening is the drug is presumably hitting EGFR and creating some of these side effects. We also see some liver function abnormalities that's shown here with the AST, ALT. We see some nausea and we see some dry skin. When we think about targeting this pathway from the outside, this is using an antibody drug conjugate. And let me just explain what that is. That's a antibody that targets HER2. That antibody is connected to a very powerful chemotherapy. And then that chemotherapy goes into the cells that have that cell surface expression, in this case, HER2. One interesting side effect that we're starting to see more of with this type of treatment is something called interstitial lung disease, or ILD. And this typically occurs about 5 to 9 months after treatment. Here's an example on a CT scan, pre-treatment and after treatment. And then this is what the biopsy also looks like. When we think about what are the factors associated with this serious adverse event, that's shown here in this nice diagram. I would say one of the biggest risk factors is whether the patient has underlying lung disease and needs supplemental oxygen. And then the other thing to note is that the median onset to ILD was about 5.4 months. So how do we manage this serious side effect? I've put a lot of text here, and I'm not necessarily going to go over it, but I will say that one of the mainstays of treatments is to start high-dose steroids and to permanently stop treatment if the patient has what's called grade 2 or grade 3 side effects. So I'll just leave this here as a reference. So the key points I want to emphasize from this portion of the talk was that about 45% of patients with non-small cell lung cancer will have actionable genomic alterations. And there's an enrichment in patients who've never smoked. Now, this is not to say that patients with a smoking history can never have this. In fact, my view is you should check anyone with lung cancer and do broad-based molecular testing. But it's helpful when we're thinking about probabilities of what mutations are more likely where. The onset of these drugs, especially the tyrosine kinase inhibitors, is really fast. So most patients will typically report symptom improvement in 3 to 4 days. Conversely, the side effect onset is very fast. And this is relevant when we're thinking about specific side effects like pneumonitis. And this helps us think when we're using treatments like tyrosine kinase inhibitors versus other types of treatments like chemotherapy or antibody drug conjugate. And we can certainly have a conversation about that. Antibody drug conjugates such as TDXD have a very high risk of ILD. This is a really serious side effect, and management is starting to continuously evolve. So I want to finally end with just a quick couple of slides on the impact of biomarker testing. So what we do know currently is in the real world, biomarker testing remains suboptimal. This is a very nice paper out of JCO Precision Oncology that shows that smoking history continues to remain a significant determinant of whether patients receive biomarker testing. This is in spite of the NCCN recommending broad-based NGS for all patients with non-small cell lung cancer. And in particular, biomarker testing for MET exon 14 skip and BRAF V600E, these are different mutations that also have targeted therapies available, is low. It's around 56%. And this paper is really impactful, in my opinion, because it really shows that suboptimal biomarker testing leads to worse outcomes. So on the top left here, you see that approximately 14% of patients who have an actionable genomic alteration actually never receive targeted therapy. When you look at those patients and you see those who are non-adherent to the guidelines, they have a worse overall survival. And there's a lag between when a new therapy is discovered and mentioned in the NCCN and when the community oncologists start recommending this as appropriate targeted therapy. And that's shown in the bottom right diagram here. And so my take-home messages from this talk are that biomarkers are crucial in lung cancer. They guide management decisions. The treatment options for EGFR and HER2 mutant lung cancer include highly effective targeted therapies, such as TKIs like osimertinib, zongertinib, and cevabertinib. Those latter two are for HER2 altered lung cancer, or antibody drug conjugates such as TDXD for HER2 mutant lung cancer, and more recently, there's a drug called Dato-DXd for EGFR mutant lung cancer. And finally, suboptimal biomarker leads to worse outcomes. So with that, thank you.
Thank you, Dr. Patil. That was wonderful, and you actually gave us 3 minutes back, so you finished 3 minutes earlier, which is great. So next, I would like to introduce Dr. Christina Bake, who is an associate professor at the University of Washington Fred Hutchinson Cancer Center, and she will be discussing management of KRAS and BRAF mutations. Welcome, Christina.
Hello, everyone. I will share my slides. Let's the slide view is set. So great. Thank you to the organizers for giving me an opportunity to speak this morning. And thank you, Dr. Patel, for really setting the stage and giving high-level overview of lung cancer in general. And I'll be really focusing my talk on the KRAS and BRAF, a mutated non-small cell lung cancer. So let's talk about KRAS first. I first want to emphasize that when we talk about these genetic subtypes, we are really talking about non-small cell lung cancer. And often we're talking about a subtype of non-small cell lung cancer called adenocarcinoma. So I do want you to keep that in mind. So KRAS mutated lung cancer is common. It makes up about a quarter of non-small cell lung cancer. Now, this is a type of lung cancer for which we haven't had a targeted therapy for many years, even though we've known about it for decades, really. But the first targeted therapies came about 5 years ago. And since then, there's been an explosion of new therapies in clinical trials, new approaches. So really exciting times for this type of lung cancer. Now, I do want to point out that it's very important to know what type of KRAS one patient might have. So there are many different subtypes. Most common are G12C mutation. Other common ones are G12D, as well as G12V as in vector. So when you look at your molecular report, really important to really look through the subtypes of KRAS. And the reason this is important is because treatment approaches are different, and the targeted therapy we have now is really specific for G12C. And these treatments do not work if patients have KRAS but the other subtypes. So who are the patients? So this table comes from a clinical trial of KRAS G12C patients. Now, Dr. Patel had mentioned that often these genetic subtypes are enriched in patients who don't have a smoking history. I would say some of the KRAS is one of the exceptions. So if we look at smoking history, the majority of patients have a smoking history, many of whom, or majority of whom, have quit already, but still have the risk of developing lung cancer. A smaller proportion of patients do not have a smoking history. We can see that about half of patients are women, so there does not seem to be a particular leaning towards one biological sex versus the other. And the other thing to point out is that most of these patients have the adenocarcinoma subtype of non-small cell lung cancer. Now, we have 2 targeted therapies that have been FDA approved. And the FDA approval is for patients who've already had a prior chemotherapy and or immunotherapy. So these drugs are called sotorasib or Lumakras, and a lot of patients know these drugs by their brand names. And the second drug that is available is called adagrasib or Krazati. So how well do these treatments work? And before I talk about the specifics, I wanted to go over some of the high-level concepts. And this is what I do with my own patients in clinic before we talk about any targeted therapy. And before I talk to them about the specifics of side effects and how well the treatments work, I go over these concepts together. So the goal of treatment is disease control. And what I mean is that we're controlling the cancer and trying to preserve quality of life as best as we can throughout the journey of the patient. So these targeted therapies can shrink the tumor or at least keep the cancer under control. So you may have heard your doctors mention the term stable disease. And this is a common term we use as oncologists to mean that patients have stabilization of their cancer, even if there's no big shrinkage. Now, many patients can have improvement of their cancer symptoms with treatment, which is great. But it's important to recognize that even though we're very excited about these targeted therapies, they cannot cure the cancer. So they cannot eradicate the cancer, unfortunately. I wish we could, but with the science that we have now, these drugs cannot get rid of the cancer. And that's why patients have to stay on these drugs to control the cancer. Now, at some point, the drugs do stop working. And because of that, really balancing the side effects while we try to control cancer is really crucial. The other piece to remember is that many of these side effects are usually related to the dose. And when we reduce the dose of various drugs, the side effects do get better. So let's talk about the specifics of these KRAS G12C inhibitors, the sotorasib and adagrasib. Chance of tumor shrinkage is about 30%. So what I mean by this is if I give 100 of my KRAS G12C lung cancer patients these drugs, about 30 of them will have major shrinkage. So that's what we mean about response rate of 30%. And you may have heard of this term response rate as well. Now, so that's not too high, but if we look at the chance of disease control, meaning if one were to take this medicine, what's the chance that cancer will at least stabilize? And that's about 80%. So that's better than 30% that I mentioned earlier. And how long does the benefit last of these two drugs? On average, about 6 months. So not too long, but it is variable by patient. So, I've had patients who were on these drugs 5.5 months and they're doing great. And they worry that in another month, their cancer will progress. It's not that. This is just an average, from lots of patients, and how long these treatments work really vary patient by patient. So it's really important to remember that. Now, because the benefit of these drugs are limited, really important to think about the side effects as well. And, I have some patients who will ask me, is this benefit really worth the side effects I have to go through? And I think that's really a fair question to ask. Whenever I evaluate new drugs, there are a couple of things I first like to look at. So the first is the question of how many or what's the percentage of patients that have to reduce their dose due to side effects? And what's the percentage of patients that have to stop their treatment because of side effects? Because this gives me a sense of how easy or how difficult medicine is for patients. So if we look at sotorasib, about 15% of patients have to have their dose reduced due to side effects. On the other hand, about 50% of patients had to reduce the dose for adagrasib. That said, about 10% of patients for both drugs had to stop drug due to side effects. So for example, for patients with adagrasib, if they have a lot of side effects, they're able to go down on the dose and stay on that dose for some time. Now, the most common side effects for these drugs are diarrhea and nausea. So if we look at sotorasib, about 20% of patients have grade 1 and 2 diarrhea. And about half of patients with adagrasib get grade 1 to 2 grade diarrhea. And what that means is, this is a way that oncologists and researchers use to define different side effects so that we can talk to each other, communicate with each other on paper in an efficient way. And grade 1 and 2 includes patients who have diarrhea, maybe once a day, maybe once a week, all the way to patients who have multiple diarrhea episodes a day. And unfortunately, a lot of clinical trial data, they lump these patients together. And sometimes it's hard to tease out, but for those patients, it's about, these percentages for these drugs. Nausea is another side effect that is very common. About 13% of patients have grade 1 to 2 nausea versus 30% with adagrasib. And this means nausea that leads to decreased food intake, but not necessarily weight loss. So we can see that the common side effects here are not usually life-threatening, but certainly side effects that can affect day-to-day life. So really important to talk to your doctor about what this means for you. For example, I had a patient in her 70s who was really healthy, very active, an avid golfer. She would go golf every other day. And when she started this drug, she couldn't golf anymore because she was having a couple of episodes of diarrhea, even 3-4 episodes of diarrhea every day, and it wasn't predictable. So she wasn't able to go out and do things. And for her, that was really not acceptable. So we decided to reduce the dose that managed this better, and she was able to go out and golf once a week. So these are really important conversations to be had. So what does a treatment journey look like for a patient with KRAS G12C? Part of it depends on other tumor markers. You may have heard of PD-L1 as a tumor marker, and other clinical conditions like other medical conditions, how frail one is, a baseline, etc. I have mentioned that KRAS drugs or G12C drugs are FDA approved as a second treatment. So we often do start with either chemo or immunotherapy, or usually chemo and immunotherapy. That's a common first treatment, and use KRAS inhibitors as second treatment. In some patients, I would even start with immunotherapy alone, depending on their other clinical factors. The point here is that patients are getting their KRAS inhibitor as their second treatment. An important point to note is that going from one targeted therapy to another usually doesn't work. So if somebody starts with adagrasib and the cancer starts to grow, going to sotorasib is not going to work because these are very similar drugs. Now, what about other KRAS mutations? So far I've talked about KRAS G12C, but what about others? So I wanted to highlight G12D. Right now, we don't have any targeted therapies for this particular subtype, but there are many that are in development. Now, this is a common subtype of KRAS, and many of these patients have what we call mucinous adenocarcinoma, and I'm here showing a picture of a CT scan. So this lung cancer, instead of showing up as discrete masses where we can measure, this shows up as this sort of cloudy area in one part of the lung, and it can look very much like a pneumonia. So it's not unusual for me to see patients who've gone through multiple courses of antibiotics because of this finding, ultimately get a biopsy and are diagnosed with lung cancer. And this is often found in patients with minimal and no smoking history. So I think this is an important type of KRAS mutation to recognize. Now, there are many new drugs that are in development, and I am listing some of them just for your awareness. We Now, they look very promising in labs, in animal studies, but we don't fully know how well they work in patients. And these are in clinical trials. It's very exciting that there are so many drugs that are in clinical trials. The thing I wanted to point out here is that if you're interested in participating in any of these clinical trials, the best way to go about is really talk to your oncologist to figure out where is the closest cancer center near you that may have one of these clinical trials. So I have mentioned in the very beginning that research is exploding in KRAS, which is great. There are a number of new KRAS G12C inhibitors that are in clinical trials. There are many combination therapies. So, for example, KRAS inhibitors are being combined with immunotherapy. Some are combining with chemotherapy. So, many combinations that are in research. Dr. Patel mentioned about antibody drug conjugates. There are what I consider smart chemos. These are being researched in KRAS patients. And finally, there are many new targeted therapies for other mutations as well. So really, a lot of data, a lot of new information to come in the coming years. All right, I'm going to change gears to BRAF. So unlike KRAS, BRAF is quite rare, and it's about 3% of patients. And similar to what I mentioned for KRAS, there are different types of BRAF mutations. The most important one, at least right now, is V600E. And the reason I say it's most important is because we have treatments for it. The other BRAF mutations, there are certainly clinical trials that are ongoing, but no targeted therapies for these types of mutations as of now. And I'm going to focus on V600E mutation going forward. And this is quite rare, 1 to 2% of patients. So, this is often missed or not tested because it's rare. So, for example, patients go through their initial testing with their biopsy, and let's say that they run out of material and BRAF hasn't been tested. Often this is not being tested with a second biopsy because it's so rare. But what I would say is that for patients who do have it, it can really change their trajectory in terms of treatment options. So really important to test. So who are the patients? In terms of smoking history, most of patients have some form of smoking history, but about a third of patients do not have a smoking history. And most of these patients have the adenocarcinoma type of non-small cell lung cancer. Now, there are 2 combination treatments that are FDA approved. One regimen is called dabrafenib and trametinib. My patients usually refer to them as Tafinlar and Mekinist. I usually call it dab-tram. I am going to call it dab-tram going forward. Another regimen has 2 drugs as well, encorafenib and binimetinib, and their other names are Drugtovi and Metovi, and a lot of doctors will refer them as Encobini. Now, unlike other targeted therapies for BRAF V600E, we need both drugs for higher effectiveness and to reduce chance of skin cancer. So quick science. So this is a cancer cell. This is the membrane or the lining of the cell. And the proteins that are activated that leads to cancer growth is these right here, RAS, RAF, MEK, among others. So one of these drugs like dabrafenib and encorafenib goes after RAF. But what happens is that if you only target this, the protein underneath of MEK can get activated and become problematic. So for this type of mutation, we need to inhibit or or block both BRAF as well as MEK. So for example, encorafenib blocks BRAF and binimetinib blocks MEK. So we need both drugs for to achieve higher effectiveness. So how well do these work? First, both regimens are FDA approved for any patient, so it doesn't have the requirement of needing to receive chemotherapy or immunotherapy first. And one point I should mention is that Encobini, that regimen is better if we give it as first-line treatment, and that means receiving as the very first treatment after diagnosis, and the efficacy looks to be good. In terms of tumor shrinkage is quite, the range is quite large. The chance of tumor shrinkage is 45 to 70%, meaning 45 to 70 patients out of 100 patients can have major shrinkage. The higher range is for patients who receive these drugs in the first line. And chance of disease control is also 40 to 75%. And how long how long does the benefit last? Again, the range is quite large, anywhere between 9 to 30 months, with longer duration of benefit if these treatments are given first, particularly for Encobini regimen. That said, the side effects of these drugs can be quite difficult. And in my own experience, these are more difficult than other targeted therapies. Usually, the one side effect that is notable for Daptrem is fever. So a lot of patients, almost half of patients can have drug fevers. Nausea, vomiting, diarrhea can also be common side effects. For Encobini, more nausea, diarrhea, fatigue, some of these gastrointestinal side effects. Patients can still have fevers. These are drug fevers. Again, these do get better with lower doses. So that's something to consider if the side effects are really not tolerable. I do want to talk a little bit about some of the side effects that are common. I want to first talk about fevers. So fevers can occur within days of starting treatment, and they can kind of feel like flu-like symptoms. Feel like you're coming down with an actual like a viral infection. And they can be associated with shaking chills, and they can really look scary. And even for a doctor, it can be difficult to tell if the fever is coming from the drug or an infection. So for the first episode, really best to see a doctor to make sure it's not an infection. And once an infection is ruled out, one can use things like acetaminophen or Tylenol for fever management. And holding drug can be helpful. And if the fevers are recurrent, low-dose steroids can be helpful. Other uncommon but notable side effects include decrease in heart function. So your doctor may order a baseline echocardiogram. Excessive bleeding is another thing to remember. So really need to let the providers know if you have any bleeding at baseline, like blood in your stool or blood when you cough. Really important to let your doctors know. And skin cancer is uncommon, but really need to be aware. So I wanted to show a picture of what that looks like. Many people can recognize melanoma because it has this dark look to it, has irregular borders. So squamous cell skin cancer can look like an infection in the beginning and has a little crust on top of it. But the key is that if you notice something like this and it does not go away, really important to see a skin doctor. And in terms of treatment journey, often patients do start with their targeted therapy and followed by other drugs. But there are some patients where I am worried that they're not going to be able to tolerate these targeted therapies. management of fevers on their own, then I may actually and may start with an immunotherapy, especially if they have other factors that makes me think that they are going to benefit from immunotherapy approach. Again, going from one targeted therapy to another usually doesn't work. So that's one thing to keep in mind. Again, there are future promising treatments, including in patients with non-V600E mutation. I listed them mainly to point out that these are in clinical trials. So in summary, KRAS is a common mutation in lung cancer. G12C is the most important one to recognize right now, and there are a number of targeted therapies and many clinical trials and combinations in development. And there are treatments for other types of KRAS that are in clinical trials. BRAF is rare, and targeted therapies can work very well. However, side effects can be challenging, so important to work with your clinical team closely. That's my last slide, and thank you for your attention.
Thank you so much, Dr. Bake. I've been looking at the questions that are coming up, and I am very impressed. The questions are really hard and very interesting. So I'll go ahead and we won't be able to go through all of them that's posted, but I'll try to do the majority of them. So the first question, I think that's very important, and I'll just whoever wants to take it. So when we were talking about targeted therapies, sometimes, like for example, in EGFR, we use it in first line, and then, for KRAS, we use it in second line. So after the treatment, the first treatment stopped working. How do we make that decision? How do we decide if the patient has an oncogenic driver? Should they go on targeted therapy, or should they go on chemoimmunotherapy and use targeted therapy when chemoimmunotherapy stops working? So maybe I'll have Dr. Patil try to answer that question.
Yeah, it's a good question. I think the most straightforward answer is that some of this is contingent on how the drug was studied and in which context. So a lot of times in drug development, a new molecule will be studied after patients have received standard of care. And then as the drug shows more and more promise, it makes its way further and further in the earlier and earlier in the treatment journey. And then you start to get what's called a first line study. So usually that's how we first decide. Now, to add a little more nuance to that question, there are some oncogenic alterations that I think really should be thought of as non-immunogenic. And what I mean by that is that the likelihood of an immunotherapy adding much is very low. And here I'm specifically thinking of treatments for oncogenic drivers like EGFR, ALK, is ROS1 and RET fusions also fall in this category. There's a lot of emerging data, not just from the trials, but from large retrospective series that show that really these patients, if you just give them single agent immunotherapy, they don't really do well and they don't respond. Now, Dr. Bake has the harder job of trying to explain this in KRAS, because I think there's a little bit more of a mixed signal, and I think the sequencing strategy is a little bit harder. So I'll focus on EGFR real quickly. So I think the FLORA2 study and Mariposa studies have really established that some kind of combination strategy for patients with EGFR mutant lung cancer is probably the correct first step. For the longest time for HER2 mutant lung cancer, we had to unfortunately do some kind of chemotherapy plus minus immunotherapy. I will mention that actually very recently, zongertinib just got a first line approval for HER2 mutant exon 20 insertion positive lung cancer. So I think the landscape is rapidly changing. I would not be surprised if in a year, if we did this talk, we will have a very different treatment landscape for HER2.
Thank you so much. Dr. Bake, do you have anything to add to Dr. Patil?
Yeah, I think I would say, as in general principle, targeted therapies do result in rapid tumor shrinkage, symptom improvement. So I think using targeted therapy first is typically the approach, but KRAS is an exception because the um, how the FDA approval came, but also the chance of tumor shrinkage and how well it works is much more lower than typical targeted therapies. So part of it is deciding, what's gonna result in better benefit upfront. There are some patients who might do better with immunotherapy from a tolerability and potentially longevity. So I think for KRAS, it's really um, even for BRAF, I think it's really case by case sort of discussion with patients.
Thank you. So another question I have, it's for you. So you've discussed several types of KRAS mutations, and is the type of KRAS mutation differs based on the patient prior smoking history. Like, not that we're gonna, we've discussed it in the first session. We are not making decisions to test, not to test based on smoking history. We test everybody. But if you compare two patients, one has a smoking history, another does not, will the KRAS mutation type differ in those patients?
Yeah, I think we're starting to understand more and more about that. We know that most of KRAS lung cancer patients do have some form of smoking history. However, I mentioned the KRAS G12D, D as in David. That subtype looks to be common in patients who don't have a smoking history. So I think that's a distinction. And I think the distinction in terms of treatment options for KRAS is that their likelihood, meaning patients with G12D versus other KRAS, their likelihood of responding to immunotherapy probably will differ. We don't have really direct, data one way or another. So I anticipate that G12D patients would be a different patient group compared to rest.
Perfect. Thank you. Next question I have is to Dr. Patel. So we've talked a little bit in the first session about different mutations, like the oncogenic drivers versus non-oncogenic drivers. In EGFR setting, we actually see, not commonly, but sometimes, a patient who have mutation, let's say classical EGFR, let's say deletion 19, and in addition, they will have p53 mutation and RB1 mutation. Does it mean different things to you if the patient just have a mono EGFR classical mutation, or if they're commutated with TP53 and RB1?
That is a really good question. I think right now it doesn't affect our selection of therapy. I would still offer this patient first line combination therapy, whether it's osimertinib plus platinum pemetrexed chemotherapy, that's the FLAURA2 regimen, or amivantamab and lazertinib. And I don't really make a distinction between which treatment choice I use based on whether they have a TP53 and an RB1 mutation. Now, that being said, those mutations do confer an increased risk for small cell transformation. I will say it's not a one-to-one. So what I mean by that is if you have a TP53 and RB1 mutation at baseline, it is not guaranteed that small cell transformation is in your future. It's rather the other way around. If patients have small cell transformation and then you go and look back, there's like a 50-fold increase of risk for small cell transformation. And so it's a little bit of a selection bias. But that being said, it's an interesting question of in the field, should we start moving towards some kind of intensification strategy for patients who have TP53 and co-occurring tumor suppressor loss, such as RB1. TP53 is an interesting mutation. It's very common in cancers, and it has been consistently shown to be associated with the worst subtype, but it's a little hard to disentangle some of this because I think the subtypes that do worse are TP53 plus something else, not just TP53 by itself. I'm not necessarily persuaded by the literature that TP53 just single alone is the negative driver. There's a lot of good retrospective theories that have shown the co-occurrence of TP53 with like CDKN2A or RB1 loss. Those really are higher risk. So I think there's a lot to learn here. I don't think we have the full story. Does it change my immediate treatment plan? It doesn't.
So I want to kind of maybe explore a little bit more what you said about small cell transformation. Can you briefly explain to us what small cell transformation is? How do we diagnose it? And maybe highlight the benefit of post-progression biopsy in patients who develop resistance. Let's just stay in EGFR space.
Yeah, so in my talk, I talked about how there's non-small cell lung cancer and then there's chemotherapy for small cell lung cancer. So small cell is a different subtype of lung cancer. It's characterized by a neuroendocrine phenotype, and they tend to be much more aggressive and are typically treated with chemotherapy, typically some kind of platinum chemotherapy and another drug called etoposide. The challenge here is that we really, as of 2026, the gold standard is still tissue biopsy to look for the changes that we see and are associated with small cell transformation. So transformation means a patient had an EGFR lung adenocarcinoma when they were first diagnosed, and then through some selection process after starting the treatment, that cancer has now switched from adenocarcinoma to small cell and is behaving way more aggressively. That's what we mean when we say small cell transformation. And that's a increasingly more appreciated mechanism of resistance. It's hard to call it a mechanism of resistance, but I guess it is in some sense. And the challenge has been how to define that. And as of 2026, the current standard is still a tissue biopsy.
Thank you so much. Next question I'm going to pose to Dr. Baik. You've talked about efficacy of KRAS inhibitors, but do they work for patients who have brain metastasis? So what do we know about efficacy of KRAS inhibition in patients with brain metastasis?
Yeah, I think part of the challenge knowing the answer to that question is how the clinical trials have been done. So a lot of clinical trials will only accept patients who have what we say control brain metastases. It's difficult to know truly how well it works out in the real world. Having said that, we have data with the use of adagrasib that it can work in the brain, and it's limited data set. There is even more limited data set for sotorasib. So because of that, if I have a patient with brain mets with KRAS G12C, I tend to go with adagrasib, even though the side effects are a bit more. However, the data, I want to recognize that the data is limited for both drugs.
Thank you. Another question, when I read it, I actually smiled because I'm constantly humbled by the questions patients give us because we are used to speak in certain terms, and sometimes it's hard to realize that our patients really don't know those terms, so they need to like have a new dictionary. So the question that came in, how do you describe quality of life metric for targeted therapies? So what's quality of life in our eyes? How do we measure quality of life? Whoever wants to take it, just go ahead.
Yeah, there's a very specific way it's defined in clinical trials. Oftentimes they're using validated questionnaires. So one very common one is an EORTC questionnaire. It's a very standardized assessment that is given to every patient on a study, and then you can sort of remove some of the subjectivity that comes with it. But I will say that ultimately quality of life is inherently very subjective. And I think what one patient finds, quote, tolerable and what another doesn't totally depends on their own life experiences. And so it's a bit of a way to take a very nuanced topic and try to normalize it, but it is a hard question. It's a great question. There's not a clear way to normalize it. I mean,
Yeah, I would say, yeah.
Oh, sorry, I was going to add one more point. I think that like when I talk to patients, I just take every patient case by case, though that for the purposes of understanding data, it's probably not possible. And that's where these sort of normalized questionnaires come from.
We're just going to say that the exact same thing that you just said, which is difficult to explain this in clinic because everybody's quality of life definition is different. So it's unusual that I would say, oh, in clinical trials, this was a score, right? Quality of life score. So it's an individual conversation.
Thank you. Another question we have about 3 minutes left. So another question that's coming I think, very interesting. So, Dr. Patil, you discussed antibody drug conjugate for the HER2 mutant non-small cell lung cancer. The question is, if antibody drug conjugate work on one type of mutation, why don't they work on all of them? So what do we know about ADCs? How do we decide which setting to put the ADC in?
That's a very good question, and it's actually a much more challenging question to answer. So I think some of this depends on how much you believe so let me just take a step back. The antibody drug conjugate is an antibody that targets some kind of cell surface protein and is typically linked to a chemotherapy payload. So the logic is that there more of this protein that's on the cell surface, probably the better the antibody drug conjugate will do. And there are some protein pathways like MET and HER2 that where this seems to be the case, but then there are other pathways where it doesn't seem to matter as much. And I think TROP2 is a good example of this. I think TROP2 is a cell surface marker that just seems to be present on lung cancer. I think it's a little bit more of a I don't think we fully know how it dynamically changes in response to treatment. But in terms of selecting therapies, again, a lot of this will just come to what was the trials that got the drug approved studying, right? So TDXD, which was a HER2 antibody drug conjugate, explicitly studied patients with HER2 alterations. They didn't look at ALK rearranged lung cancer. They didn't look at RET. I suspect they wouldn't have as good responses, but we will never know because that trial was never done. I think from a biological reason, it makes sense to focus the antibody drug conjugate based on what's on the cell surface. I think what's going to get very difficult, and here I'm starting to get a little bit in the weeds, I'm trying to just gauge how much I should go into this, is, the question is really asking this fundamental distinction between genomic testing, looking at the DNA of a cancer, versus looking at the cell surface expression of a cancer. And they may not necessarily be one-to-one. And I think that's going to be a very challenging place. Sorry, that might be a little bit more of a technical answer, but it's a very hard question. So
that's why I liked it. I think it's a very hard question. I think we are still learning which ADCs would be acceptable for what mutation. In case of HER2, there is maybe some biological rationale, and patients with HER2 mutations maybe will grab the antibody and internalize it more effectively. But I think it's work in development at this point. So as I mentioned earlier, my job is to be a time police today as well. I see we are at time for the Q&A session. I'd like to thank from the bottom of my heart both of my presenters for donating their time during the Saturday weekend. And I know Dr. Patil is actually covering the hospital, so he has to go back and see some patients. Thank you so much. And then we'll move on to the next part of our presentation. Thank you. All right. Let's go ahead and move on to the next topic. It is my pleasure to, see, I'm smiling, introduce my very good friend, Dr. Isabel Prashagi from Memorial Sloan Kettering Cancer Center, and she will be having a very difficult task of covering 3 mutations in 20 minutes. So ALK, ROS1, and RET. Go ahead, Dr. Prashagi.
Thank you so much for the very kind introduction. Just gonna share my slides. Can you see?
Yes.
Okay, wonderful. So yes, I have been tasked with talking about 3 very exciting fusion alterations. I'm going to keep it really high level and very high yield, and hope you can stay with me. Okay, so here are my disclosures. Briefly going to talk about next generation sequencing in general, which I know you've heard about quite a bit today, but just going to take it home a bit. Talk about TKI naive versus pre-treated setting and how you should approach that for patients with ALK fusions, ROS1, and RET. And then we have a take-home message. So, as we've heard today already, lung cancer is complex, right? One size does not fit all. So previously, it used to be okay to just start treatment. It wasn't a big deal. But now we know that we can't just start treatment, right? We need to know about the personality of everybody's tumor. We need to know about your next generation sequencing or biomarker testing or mutation testing, genetic testing, whatever have you, tomato, tomato. We need to know about the molecular setup of your tumor. So why is this so important? Well, way back when, decades ago, we used to know non-small cell versus small cell. Then it got a little bit more hairy when non-small cell was broken down to adenos, squamous, large cell neuroendocrine. And then it became even more complex when we realized that there were molecular alterations that were driving tumor growth, like EGFR, ALK, KRAS, and BRAF that you just heard about. Then to add more complexity, in addition to alterations, we also want to know about expression of PD-L1, right? And as of late, we've learned a lot more about these protein expressions, right? We need to know about TROP2. We want to know about MET and HER3 and HER2 overexpression. These things are all features that help us figure out what the right cocktail is for our patients and what's going to help their tumor the most. So what is next generation sequencing, right? So it is basically taking the tumor and getting a large scale DNA sequence of all of the tiny little exons that make up that tumor gene, right? So there's lots of different ways you can sequence it. But when we're talking about DNA sequencing, if we're querying the entire genome, that naturally is called whole genome. When we're looking at the exons within known genomes, that's called whole exome. And then when we're just looking at specific exomes, that's more of a targeted panel. So I would say if you ever see that you're just getting a targeted panel done, that is not comprehensive. And it's really important that you ask for whole genome sequencing. And if that's not possible, at least whole exome sequencing. But you want your entire DNA to be sequenced. And this ideally should be done on tissue, right? Your actual biopsy sample, as well as from a blood sample. So I'm talking about fusions today, right? And the reason I'm bringing this up is because a lot of times fusions, especially the ones I'm talking about, get missed with just DNA sampling, right? So we have to make sure that we ask, not only are you sequencing the tumor forward with the DNA, but also you need to go backwards with the RNA, because when you go backwards that way and you do RNA-based testing, you can pick up on things that you might have missed, right? You might be missing introns. You might be missing certain frequencies with repetitive introns. You might be missing certain alterations if there was a low tumor sample, right? Or if there's sort of complex genomic events. This is why you need to make sure that you advocate for yourself and you ask for DNA and RNA-based testing. So let's talk a little bit about a study that was done with RNA next-gen testing, right? So you have RNA next-generation sequencing for a targetable kinase in about 254 lung adenocarcinomas, right? So they sequenced 254 patients with adenocarcinoma of the lung, and of those 254, none of them had any alterations, right? They did DNA-based testing, mind you. Then they ran RNA-based testing on those 254 tumors, and they were able to identify 36 patients with alterations. That's 14% when they had previously had no alterations detected. That's a huge deal, right? That's really important. You're impacting someone's life, you're impacting their treatment plan, you're impacting their treatment options. So please, 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 if you take home any message from this, whether it's drugs or toxicity or whatever have you, it's really important to ask for DNA and RNA-based testing. Okay, so let's talk a little bit about how this DNA and RNA-based testing is done, right? You can either do it sequentially, where you first run DNA-based next-generation testing, and if there's no hits, then you say, okay, let's run this sample for RNA-based testing. Or you can do it at the exact same time, where you run DNA and RNA at the exact same time and it gets your answer faster. So what are the pros and cons of that, right? So sequential testing, meaning starting with the DNA first and then going backwards and doing the RNA, is good, right? It's more judicious. but it may be more expensive, right? So it's rapid, you get your answer faster, you're able to update the patients a little bit more, you're potentially not missing things, you're not forgetting to request the RNA-based testing, but it is expensive, and perhaps the institution doesn't have those capabilities. So then most folks fall on sequential testing, which is fine. It's cost effective. I would say it's more common. But it can delay results, and you're delaying figuring out if there are treatment options for your patients. So it's a little bit of a push-pull. I wouldn't say there's a right answer. The right answer is to make sure that you're getting both of these testings done, whether it's sequential or it's concurrent. So now let's dive into the treatments. So let's say you have a targetable alteration, right? And then you have a biopsy on it. You're looking within that biopsy to see if you have any evidence of resistance alterations, right? So you're on a certain target. Unfortunately, it's not working. Your doctor says, hey, we got to biopsy you to look for resistance. What's going to happen? So that piece of tissue that they biopsy to look for resistance is either going to find this unknown or known target alteration, which you can target that resistance alteration, or you're going to find out that there's some off target, some unpredictable kind of reason why this tumor is not working, in which case you might more likely proceed with platinum doublet chemotherapy or maybe even a clinical trial. So let's start with ALK fusions. So ALK, as we know, this is a fusion. It's when the ALK gene decides to hold hands with EML4 when they should not be holding hands. And it's this holding hands of these two exons is what leads to tumor growth, unfortunately. So when you're looking at patients with newly diagnosed stage 4 non-small cell lung cancer harboring ALK fusions that have never had any treatment at all, right? We have 4 amazing options. We have lorlatinib, we have alectinib, we have brigatinib, we have ensartinib, and then there's also crizotinib, but that's fallen out of favor, and as well as ceritinib, but I just removed those. So when looking at lorlatinib, alectinib, brigatinib, and ensartinib, the reason I put some green boxes around certain areas is because I want to draw your attention there, right? We want to look at progression-free survival. We want to look at, is this drug going to make me live longer, or am I going to have better quality of life, or what are the outcomes of the study that led to this drug? And I highlighted the numbers that I thought were very impressive to me, right? So you have a 5-year progression-free survival of 60%. Whereas if you look at alectinib, it's only about 41%. The thing that is most remarkable about lorlatinib is its ability to penetrate the blood-brain barrier, and it has been shown to actually treat patients with brain metastases and also have this sort of protective effect with patients to prevent brain metastases from growing. And as we know, unfortunately, patients with ALK fusions, they very commonly develop brain metastases. So anything you could do to kind of get ahead, protect the brain, and prevent there from being any metastatic disease from developing there is really, really, really important, right? So you see a PFS hazard ratio of patients with brain metastases of 0.08, which is outstanding. And then you see a hazard ratio of people without brain metastases of 0.24. That's greater than half what's seen in alectinib and brigatinib, right? So it's really protecting the brain. So this is super, super important. So anybody with brain metastases with an ALK fusion, I always think about lorlatinib first, obviously after talking to them about shared and informed decision-making and making sure that there aren't any certain contraindications why they should not receive this medication. In addition to that, we always have to also think about toxicity, right? Because what we call tolerable, we have no idea. Fortunately, I have not been taking these drugs, and I can't say that something's tolerable unless I've tried it myself. So I have to go off the data. And it does look like, based off these 4 drugs, that there are not as many grade 3 adverse events with alectinib compared to lorlatinib and compared to brigatinib. So the toxicity profile of alectinib may be more favorable. So let's talk about 4th generation TKIs, right? These are in patients with pretreated disease. And mind you, this drug I'm going to talk about is still in clinical trials. So please take this with a grain of salt. But this drug is revolutionary, right? It's called neladalkib. It's a mouthful, also known as NVL-655. It's a drug made by Nuvalent. And what I really like about this drug is it's a fourth generation tyrosine kinase inhibitor. It has efficacy in patients that have previously received lorlatinib, as you can see in this star over here. And it also has efficacy in patients that are lorlatinib naive, right? So we're always thinking about the marathon, right? How can we sequence these drugs? How can we make the most of it? So there are many clinical trials out there with neladalkib. If you are on an ALK drug that is not working for you or you're newly diagnosed, I really encourage you to ask about these studies, okay? Moving on to ROS1 in the interest of time. So ROS1 gene fusions occur in about 1 to 2% of patients. It shares a lot of similarity with ALK. It's usually picked up on IHC, but often can be missed on IHC, which is why you need DNA and RNA-based testing to detect these fusions, right? So let's talk a little bit about the drugs, right? We have crizotinib, entrectinib, repotrectinib, and taletrectinib. And then there's also a newer drug in the pipeline called zidesamtinib that I'm going to talk about later. So when looking about these drugs, I really favor repotrectinib and taletrectinib, and I can tell you why. It's because they have thought about resistance up front, right? We know that the G2032R is a very known common resistance mechanism why crizotinib stops working for these patients. So to get ahead of that and to kind of already attack the bypass mechanism, that puts repotrectinib in a class of its own. Then when looking at taletrectinib, this has CNS efficacy because unfortunately patients with ROS1 fusions also develop CNS metastases. So it's really important to get ahead there, similar to lorlatinib, and it also has efficacy against the G2032R resistance mechanism. These drugs have high response rates, they have good CNS penetration, so always think about repo or taletrectinib. So let's move on to this diagram because I think it's actually very, very interesting and a very helpful way to display the data. So on the right-hand side, you have your second generation, which is like your newer, more refined generation tyrosine kinase inhibitor pills. And on the left side, you have your older first generation ones. So you can see that the size of the orb is and where it's located on the graph is telling you how high is the response rate. So you want something that's really high up on the graph. And how long is the progression-free survival? So you want something that's really all the way to the right as well. So when looking at repo and taletrectinib, you can see that they're both all the way to the right, which is nice. They're both high up. But taletrectinib, why is it white versus repo, which is red? Adverse events, right? So historically speaking, taletrectinib may have a lower toxicity profile. I have noted that in my clinic as well. So I tend to favor that over repo. So also when looking at patients that have previously been treated, like let's say you were on crizotinib already, you can see that who has the most efficacy against that resistance alteration, that G2032R, and really taletrectinib is 62% versus 59%. I know we're splitting hairs, but if you're asking me to give this talk, I have to give you my true thoughts and look at the data. So here it is. So I would say between taletrectinib and repotrectinib, it's really not all that much of a difference, but I do think taletrectinib might have a slight leg up. And then here we have our third generation tyrosine kinase inhibitor, zidesamtinib, right? It's also a nuvalent drug, NVL-520. This is a beautiful water plot, and these are patients that have previously received ROS1 treatment. So if you're on a ROS1 drug that's not working, think about this study. It's open all over the place, actively accruing. Ask about studies, always. Don't save them as a last-ditch effort. Finally, moving on to RET. So RET fusions also occur about 1 to 2% of the time in non-small cell lung cancer, typically detected on FISH, but as you know I'm going to say, you need RNA-based testing to make sure you're not missing this. So when choosing between RET inhibitors for patients that have never been treated before, you have selpercatinib and pralsetinib, right? So, but here we have that bubble plot, right? So you can see the higher up, the greater the PFS, and the more to the right, the greater the response rate. So as you can see here, I had to make this comparison, and perhaps selpercatinib may have slightly better efficacy than pralsetinib. When looking at the median PFS, it's 22 months versus 13.3 months, but obviously each has different toxicity profiles, which I'm going to get to here. And it's really important to talk to your patient and their caregivers about what's important to them and use shared and informed decision-making, always, right? So we think about toxicity. I'm going to briefly go over this in the interest of time. We have to deal with xerostomia, which you might think is not a big deal, but having a constant dry mouth is going to impact your teeth. You're going to get a lot of cavities. It impacts your ability to speak. It impacts what foods you can eat. It's actually quite debilitating and a really big deal. So we have to be masters at diagnosing this, picking up on it early, and involving our dental and dermatology colleagues right off the bat. It can cause this false sense of renal insufficiency, sometimes hypersensitivity of the skin, and also this chylous pleural effusions can develop. Antibody drug conjugates, not something to lose sight of. They really are making their way, especially in patients with RET fusions. So please, please, please ask about antibody drug conjugate clinical trials. As you can see here, when looking at TROP2, MET, HER3, EGFR, ERBB2, there really is a lot of excitement around these new drugs. So please make sure you ask for immunohistochemistry, HER2, and MET staining, and all of these other stainings to help us figure out what drug might be right for you. So to review, we have ALK, we have ROS, we have RET, we have lots of treatment options. We have treatment options that are good in the frontline setting. We have treatment options that are good in the second line setting. As you can see, I'm highlighting here clinical trial, clinical trial, clinical trial. Never lose sight of that. That's how we move the needle. That's how these drugs got approved years ago, because someone was brave enough to go on a trial. So please don't lose sight of that. We put our most fit, most promising patients, most motivated patients on study. It is not a last-ditch effort. So side effects. I wish I could give a whole talk about this because this is really where it's important. I think we see these folks in the commercials that look like they're having a heck of a time, but that's not the case, right? We know that's not. We see these patients in clinic. We hold their hand. We call them on Sundays when they're at the pharmacy and the cream that you prescribed is $500 and you need a coupon and you have to help them out. Like, it's not okay. So we really need to think about toxicity and tolerability up front when making these decisions. So take home message, give your best drug first, always. Do not save it. Do not ever, ever save it. Best treatment first. Don't miss a fusion, right? Advocate for DNA and RNA-based testing. Advocate for a patient navigator. That's really my scope and my niche, and I couldn't give a talk without mentioning it. Ask if your institution has patient navigation. They will hold your hand, they will guide you, they will be the bird's eye view of your care, and they will advocate for you. And it's so, so, so important. So please always ask if there's a navigator that can be there to support you. Toxicity is real. What we deem tolerable, we have absolutely no idea. We need to ask, we need to use shared and informed decision making, right? As one of my very good friends and unfortunately patient taught me, her name is Jill Feldman. She uses this phrase and it was actually eye-opening to me. And now I use it all the time, every single day in my clinic, right? It's very, very powerful. Patient characteristics and preference is important. Phone a friend if you don't know the answer and be proactive, right? We know these drugs cause toxicity. Don't wait for them to happen. And most importantly, I just want to thank everyone on this call. I want to thank the patients. I want to thank the caregivers. I want to thank my patients and their families for trusting me, the thoracic family at MSK that I'm so lucky to work with, and then the Cancer Grace organizers for having me.
Thank you so much. Can we have the Grace team unblock my ability to be on the camera again because it says that I can't. So
Yes. Yep. Stand by. Sorry about that. Here we go.
Okay. Thank you.
There you go. Sorry about that, Dr.
Now I'm here.
Bazhenova.
So thank you so much, Dr. Prashagi. So we're gonna move on to the next presentation of today. And give me a second to get to my list. Okay, so the next one, I think it's first time I am gonna be listening to this speaker, Terry Conaran. She is a patient advocate, founder and executive director of a KRAS Kickers, which is a patient support organization. And I know Terry, but I've never heard her speak. So let's go ahead and Terry, and she will be giving you some tips on what I wish I had known when I was diagnosed. Welcome, Terry. Somehow I cannot hear you.
Terry, can you hear us? Okay, we cannot hear you. So let's see. Can you double check that your audio?
Sure.
Now
Okay.
it works. Perfect.
Now
Yay.
it works? Okay.
Yeah.
All right. I mean, I sound great. Okay, so I do have a new computer system, so hopefully you can see my screen. Is it sharing correctly? No, yes. No?
We just see your desktop.
You see my desktop?
Now we can
Yeah.
see you. Now it's good.
Perfect. Okay, good. All right. So hi, thank you for having me here. And actually, I'm really kind of sad that I have to give this talk, but I'm delighted that I'm to be able to be alive to kind of share it. So if you're wondering what I wish I knew day one of a lung cancer diagnosis, I'm sorry you need to hear this, but I'm hoping I can help you. My name is Terry Conneran, and I'm a 9-year lung cancer survivor. I got a couple disclosures. And I can say that 9 years ago, cancer came to join my family. Not because I invited it, but it was a very unwelcome guest that kind of showed up like the elephant in the room, the unwelcome, pounding, screaming elephant that needed attention from me and everybody else in the family. Because it didn't just come and join me and what I was doing, it joined the entire family. A husband, I have 3 kids. There we are. This is in January 2017 when I was diagnosed. There's my adorable husband, my 3 kiddos, and on the blonde's birthday there, her 25th birthday, they called to tell me I had stage 3 lung cancer. That's not what anybody wants, that's not what anybody is delighted with, but it wasn't my plan for my life. In fact, it wasn't my plan at all, but I had what I had, and I wanted to move forward with it. As you can see, my 3 kids, my adorable kids, and my husband, they weren't looking for this elephant to come join the family, to come stampeding in, but it did. And I learned a few things along the way. I went through treatment. I'm just going to give you a little brief history. I went through chemo. I went through surgery. I went through those things as a stage 3 patient. And we kind of thought that I was pretty much done with treatment. Went through about 2 years with no active disease, just being scanned, surveilled over like a quarterly basis. It's like got myself involved with some lung cancer groups, started to learn a little of this, a little of that, started seeing about these biomarkers and stuff as we all talked about. And I kind of was about ready to move on with my life, but just move forward. There's a lung cancer support group advisory panel and board of directors and what have you. But I got my first bad scan. I moved to stage 4 patient. I've subsequently had 5 different recurrences. It doesn't really matter how many recurrences I've had, but I've had 5 different recurrences over the last 9 years. And the reason I'm bringing that up is I want you to know it's 9 years later and I'm still here. I'm still here. Now this is the new family. 9 years later, I'm still here. I had the recurrence. I didn't know, but I'm here to share with you what it is I wish you know. What I wish you could know. And honestly, I really wish I was in person talking to you, looking at you as a human being, because that's a lot of it. Is I want to know you as a person. I wanted to feel seen as a person, and I didn't want to be just seen as just somebody walking down the street. I'd go into the doctor's office, probably similar to you. I didn't want the doctor to give up on me before I was going to give up on myself. I didn't know what that meant. I didn't know what I needed to know. I didn't know about biomarkers. I learned about biomarkers. I learned about other people that had the same thing as me, and that there wasn't just one kind of lung cancer. In fact, there's all these different types of lung cancers. Y'all have heard about them, the ALK and EGFR and ROS1, there's NTRK, there's HER2, there's all these different ones. I didn't know what I had. Finally, I went up for a second opinion. The truth of the matter is, I was really scared to go out for a second opinion. I know. We all talked about the second opinions. Today, I'll tell you to go and get a second opinion. But back then, 9 years ago, I didn't know. I was afraid to get the second opinion. I was seeing a local community oncologist, and I liked her. I thought she was fantastic. She answered my questions. She made me feel seen. She kind of made me feel heard. She seemed like a kind of a quiet sort of a lady, but I liked her. I got good enough treatment, and I thought we were in good shape. The recurrences sent me out for the second opinion, and she actually gave me permission. My doctor gave me permission and encouraged me to get that second opinion, and I'm going to do that for you. What I didn't realize is that second opinions aren't a threat to my doctor. They're actually an encouragement and an opportunity for the doctors to speak together, for you to go and see a specialist that can talk to you specifically about your type of cancer and talk to you in terms that you understand. It's not necessarily you didn't understand it the first time, but hearing it the second time from somebody else in just kind of a slightly different perspective, somehow it made it make sense. Perfect example. My kids, they went to school. They've been told their whole life, wash your hands, wash your hands. They go to school, suddenly they're told, wash your hands. They come home, Mom, teacher says wash your hands. Really? Same thing here. Suddenly they can hear it a little differently, meaning they, your family, you can personalize and understand just a little bit better and have a little bit more confidence about what's happening in your treatment. Feel more empowered. Empowerment as a patient is amazing. You need to understand a little bit. You don't need to know about waterfall chart unless you're into it. You don't need to know about swimmer plots. You don't even need to know what a Kaplan-Meier is unless that's what you want to know. You are one person in there, and today is your time. You can have an opportunity for treatments. You can have a decision with your doctor. I want you to feel empowered to ask the question. If you don't understand, ask again. Recognize that if your treatment needs to be delayed from Monday until Wednesday, strictly because you have a soccer game, you have a family event, the 2 days is probably going to be okay. Check it out with your doctor. But that's okay, because part of this is being able to live with the cancer as you're going through it. These are a couple of notes I just have because I wanted to bring to attention that everybody in here has been talking about treatments and targeted therapies and side effects. And side effect management is a for real problem. Going through treatment, a for real problem. Getting back and forth to chemo and radiation and surgeries and all that, huge problem. But at the same time, you're doing this to have your life. And I'm here to encourage you to recognize the importance of those people that are in your family, in your circle sphere, whether it's to go play golf, to be with your kids, be with your grandkids, be with your family, do what there is, because today is that gift. And so be present in it. Don't be afraid to talk to people, the people in your family about your cancer. Don't be afraid to not talk to them about your cancer. The best question I was ever asked was by a friend of mine when I was first diagnosed. And she said, I don't know what kind of friend you want me to be. How can I help you through your journey? What she meant was she the person that I wanted to go and talk to and pretend it didn't exist and we just go to a movie? Was she the person that I wanted to come over and hold my head while I was feeling sick? Was she the person that I wanted to help do all the research? What was she wanted? And it was perfectly okay. For that person, I just needed her to just let me know that she cared. And when I knew she cared, that's all I needed. I didn't need another person telling me what thing they saw on TV or to do this or not do that or whatever. That's what I needed from her. But she didn't know what I needed until she asked. One of the things a care partner or people in your sphere, don't just say, tell me what you need. Be proactive. Make a suggestion. Hey, can I help by picking up the kids? Can I send over dinner? It's great now that we can get Amazon deliveries and get all sorts of groceries delivered and everything else. But sometimes it's nice to just not have to make that decision. The decision fatigue is real. As you're going through these different things within your family, talk to your kids, talk to your family members, and let them know where you are and what you feel. For me personally, I didn't want to move forward with all my cancer treatments until I had my will done. This scared my husband half to death. The reason it scared him is he thought that meant I was going to die. To me, it made me feel as though I was empowered to have comfort and knew things were handled before anything happened. Here I am still later, 9 years later, same will. Not a problem. But for me, it was help. I'm not saying it's what's going to help you, but have that conversation and don't be afraid. And remember, this isn't something that you asked to have, so you need to forgive yourself for whatever it is that got you there. We don't really know. Was it the cigarettes you smoked when you were in middle school behind the gymnasium? We don't know if it was because you, I don't know, use hairspray. They're not sure of anything. It doesn't matter how you got it. You got here today and you need to deal with it right now. When you're talking to your doctors, ask and ask again until it's clear. Get a complete and total copy of your reports. We've talked about biomarkers and NGS and targeted therapies. You don't know what you have unless you see it in writing. Having that piece of information is going to be crucial to helping you find what's appropriate for your treatment, for you to connect with others that have the same thing. You have to compare apples to apples, not apples to oranges. That recognition is powerful. Myself, I ended up finding out I'm KRAS G12D from my second opinion doctor. I'd asked my first one. She didn't give me any information about it. It didn't change my treatment half. It didn't change anything about my treatment because my KRAS is not actually targetable. In fact, I haven't been able to do anything for my KRAS. I haven't had any target therapy, haven't need any. Well, that's not true. I've had radiation and I've had surgery. So I guess those are kind of target therapies, but they're not a treatment pill. Anyway, as a result of finding that I was KRAS, really what I wanted to do is I wanted to connect with other people that had the same thing as me, which is why I'm such a big proponent for it. KRAS cancers are different types, different mutations across the continuum. KRAS Kickers, the organization has started, is to bring KRAS knowledge about research, advocacy, and survivorship for you. We're not playing in policy. We're not funding research. We're not begging you for bucks. We want to help you translate the KRAS cancer for you as a patient with clarity, confidence, so you can make informed decisions along with others. We're not here to take something from you. We're here to give you something with you. Why did we do this? Because I saw that all these other different groups were out there, these EGFR and ALK and ROS1. By the way, they have some very cool names, and I'm going to give you a slide with all their contact information. But what those people do is they can help you understand where you are within your treatment journey. For me, I just wanted to see somebody else that was on the other side of what I'd been through, to see a 20-year survivor of something that I had and I knew was very similar. That's empowering. That's hopeful. That's real hope. This is a little bit of what the organization does. If you're looking for KRAS clinical trials, we are doing something that no other organization is doing, where you can find the research clinical trials, and we're not collecting your data. We're not registering you. We're not tagging you in any way. You can go to this KRASHub.org and find the information about it. And we're translating that jargon into informed choices for you. Here's the biomarker groups. These are mutations that matter. If you see you have a KRAS G12C versus a G12D, whatever it is on your report, it's a different type of treatment than what you'll see with the ALK positive or with the RET positive or any of these others. Why? Because it's a completely different cancer, even though it's all lung cancer. Way B be under the lung cancer umbrella, but your mutation, your fusion, your alteration matters. I could bore you silly about what and why it matters, but the truth of the matter is you need to understand what it is that you have so you can move forward for it. But most importantly, I want you to understand that cancer is just one small part of you, not all of you, one small part. I hope it goes away. I hope you get a simple treatment and it solves the problem and you never have to worry about it again. But the truth of the matter is, as a patient, I'm here to tell you, once I was first diagnosed, it never felt like it just completely went away again. It felt like it was always that elephant kind of hanging in the corner over my shoulder. And I don't want it to come stampeding back. The reason I don't want it to come back is because I'm scared, same as any other patient, that it might. And the reason I have the KRAS Kickers and that information about all the research is strictly so I can see what's coming down the pipeline, so I understand what's next. Because for me as a patient, that empowers me to know what it's going to take if it comes back so I can fight it again. And in the meantime, recognize how important it is. What a gift, what an amazing gift it is that you're here today. So be here now in your moment. Don't spend all your time worrying about yesterday. Don't worry about all the other things. Be here and enjoy these moments. It's so crucial. I see people that are just eaten and destroyed by the worry of what can be, what might be. In the meantime, they're ruining the moment right here and right now. So for that end, although there's a bazillion different side effects and each person has different personal ones, and I'm so sorry about that, but isn't it nice to know that you're not alone in this? Isn't it nice to know that we're in this together? And I hope that you can connect with one of those other folks, one of the other groups that can help you understand a little bit more about what you're going through as you do what you need to do to live your life. And my best suggestions, my best moments are always when I love my family. And I hope that you're able to do that too. So thanks so much for having me be here. And I hope that you have even better survivorship than anybody else can. You're you're an overachiever for survivorship numbers. Thank you so much.
Wonderful. Thank you, Terry. That was wow. Um, great talk. I'm speechless. So I get a lot of questions, and I'm joined by Dr. Prishagi. Unfortunately, not unfortunately, fortunately, had a very important family event. She had to be at. So I am joined back by Dr. Bake and Dr. Herman to do our panel discussions. I am getting, Terry, a lot of questions for you. So I'm going to make an executive decision and to concentrate this Q&A mainly on your talk, because I think I really think the questions that are coming up are quite important. So the one question is, how did you first tell your family and loved ones that you had the disease? Any suggestions on how to have that conversation?
Oh God. There's no right way, there's no wrong way, there's only hard ways. And like I said, they called me my daughter's 25th birthday, telling me I had lung cancer. And I wasn't going to be that mom that ruined her birthday. And so I waited until the next day. Well, by waiting till the next day, I ended up with a pleural effusion and in the emergency room. And so there was no time for me to process how I'm going to tell the kids. They were all like, my youngest was like 21 at the time. But what I have come to find out since then, what I've lived through, let me not even say found out, what I've lived through is every recurrence I've had, like I said, I've had 5 times. Every recurrence that I've had, it's like, and for doctors, I want you guys to understand this. As a patient, I know we don't fail tests, but here's this thing. I'm going to go in and we're going to take this peek inside my body. I can't study for it. I can't prepare for it. I've got anxiety out via wazoo. And I don't know what I want to do. And in my head, I'm like, how am I going to tell the kids? What am I going to do? What is this? And what is that? How am I going to orchestrate this whole thing? And I don't have an easy answer for you other than answer the question with them. But part of it is like, you need to get it in your own heart. Okay. Try and feel comfortable in where you are within your own skin. My son, he's got an engineer mind. I had to answer all sorts of questions I didn't even understand. My youngest, all she wanted to do was give me hugs and cry. Is like, because, but I have to meet them where they're at. And if there were little ones, it would have been different. So I don't have an easy answer, but I can tell you it's hard no matter what. And do the best you that you can. And don't be afraid to ask for other supportive services. I know they have them. There's so many different social workers. They have excellent ones at different places. And a lot of times we're so wound up as patients, and this will probably hit some of the other questions. We're so wound up as patients, we forget to ask the most basic ones about our normal living things, because what am I going to do with my treatment? What am I going to do about this, and this, as opposed to how am I going to pay for, get this thing or do this next thing? So ask about the supportive services, and the nurses can be a huge help often.
Thank you. Okay, next question, back to you again. how do I connect with people who are going through the same thing? How do I personally build the community?
Okay, that's a great question, and it sounds like a simple one. Different people are going to be different parts of what your journey are. Okay, and so you need to realize that not everybody needs to be your inner circle, and those people are going to be different people. So part of it is like, what is comfortable for you? For me, my faith community and other people that were already kind of close to me, but don't be afraid to tell them, and don't be afraid to just have a group of people you don't talk to about it. Okay, it's okay, and you're going to kind of like figure that out. I've lost friends, and this is something that doesn't make sense to me, but you really do. You can lose friends because they're like, they just can't handle what's going on in your life right now. And there's nothing wrong with you. It's just part of the situation.
So another question, thank you again. What was the hardest part for you about this entire process experience, and how did you get through that?
Oh, you had another hour? uh, how do you get through it? Well, I have a Facebook group. um, how do you get through it? You get through it one day at a time, the same way you get through anything else. And, it's kind of like learning how to drive a car. You're driving down the street and you see this obstacle. Okay, well, I can either hit a squirrel, hit a tree, or run over the child. I'm going to do the best I can based on that particular moment in time, right? So I'm going to avoid the kid. I'm going to try, whatever. And so it's like just one day at a time, and hang in there. And that's why I put up that slide with the different groups, because I want you to realize that what the ALK people are going through is different than what EGFR is. And sometimes they're even on similar medications. We have similar side effects. And you'll learn things, and you can get involved. Okay, I don't want to say this. Here's the truth. Exercise. Oh God, it hurts to say that, because I know that it helps, but I hate doing it. And that might be just doing little arm circles, but giving these little bit of things that makes you feel like you're a little bit more empowered. And then there's the other side. If you don't get a shower that day, it's okay.
Thank you. And I know you've touched it upon that when your presentation, but I think this question is still posted. I want to post it again, and I know you're going to repeat what you said. What's your advice on how to best support somebody who you just found out has been diagnosed?
That's great that you're there and you're asking this question. And who you need to ask is them. But part of it is asking them, but also know what you are. Okay. Just because my husband wanted to help out didn't suddenly make him a chef because he wanted to help make food. He was much better ordering food. You know what I mean? I could tell you 1,000 funny stories that were well-meaning friends that did things. But how can you help them? Be there for them and who they are. Don't see them as a different person. Don't make it just about the cancer. Okay, they're still your friend, they're still your whoever. Let them be that person and say, hey, well, how can I help you? And what is it that you need from me? And what is it you need from me today? And guess what? As a patient, one of the things that made no sense to me until I went through it, decision fatigue is this real thing. And decision fatigue doesn't get captured in any of these surveys anywhere, okay? Because you're like, well, how's your patient doing? No patient, well, no blood pressure problems, no problems with this. And it's like but all of a sudden I go to McDonald's, I can't even remember what they serve. So it's okay to just say, hey, I don't even know what I want. Just come hang out with me and watch TV.
Mhm. Let me ask you a question that I kind of want to have an answer for. So, one of my patients once told me that since he has been diagnosed, he had a lot of friends sending them recommendations like, oh, did you look at this drug? Or did you look at this vitamin? And did you look at that? And he's like, you know what? I'm so tired of getting those messages. So my answer to him is just forward them to me and I will tell you what's important, what not. But to you as a patient, how would you advise for the patient? Because I'm one step removed, right? So I'm not getting those emails. What would you advise to the patients? How should we address those well wishes, to be honest with you? But how do you protect yourself and what do you do in that situation?
It's really hard. Okay. And so part of this is this whole thing is really hard. So let me just spit that out first. I had people that were constantly calling me and they were anti-drugs, they were pro this drug, they saw this thing on TV, they saw an infomercial or whatever, okay? And they were well-wishers and they meant well. And at the same time, I need to go through what my doctor's doing. And so I had to literally just kind of start doing this. And what that looks like for you, maybe you have an email address that they send it all to, and then you can just kind of look at it or choose not to look at it. Okay. I love the fact that you're willing to do this for your patients. Okay, we deal with this stuff. We have a Facebook group and we're like in 117 countries, right? Okay, and so in our group, we have, I don't know, 10,000 messages or something ridiculous about the same question. What do I do about this, this, and this? You can't possibly answer all those questions for all the patients that you possibly have. So talk it over with your doctor. Have them send it to a Dropbox. Get a Google document, drop it in there, and they can do their part because they feel like they're helping. Okay, and then here's the truth. The matter is, I didn't even tell my dad I had lung cancer because I knew he was going to be one of those people and I wasn't going to be able to handle it. Okay. Now, subsequently, my dad ended up dying when he was going through treatment. I'm laughing because it's kind of actually funny because if he was diagnosed, if I told him of my diagnosis and then he died, I would have felt like I caused it. But this way, I actually feel free. So I'm actually kind of like laughing about it. But he would have been the person that was like, he would have been sending me vitamins and supplements and articles and everything else. And when I just needed to lay on the couch and be a patient. And so get a Dropbox.
Thank you. I like, because this is such a unique opportunity for me, and I think for Dr. Herman as well as Dr. Baig. I'd like to see if Dr. Herman and Dr. Baig has any questions to Terry.
I actually do have one. I wonder what is on a similar vein to the question we were just answering, how I think social media has changed the way that we all consume information and what the beliefs are on medicine, interestingly, is very prominent on social media. I imagine social media is incredibly beneficial for support groups, but I imagine it can also be overwhelming at times with opinions and ideas and how to sort out what's true data-based information and what's not. How have you navigated that?
Well, we started a Facebook group. I mean, if you can't beat them, join them. But you have to be very, very intentional about what it is you're listening to and what you're listening for. Right now, it's not just social media, it's AI. And now I am a gadget lover at my absolute core, okay? And I love what AI can do from a possibility standpoint, but I'm also afraid of misinformation that's out there. Okay, and so whether it's social media or AI or whatever, you actually need to know what the sources are, what the timeline is, what the data is, and don't go changing any treatments or taking new nutrition or supplements and stuff till you talk to your doctor. And that's especially crucial if you're on any sort of a clinical trial or any of these targeted medicines. Okay, it's incredibly difficult to come back after you've made a bad decision. And that bad decision may seem like a really good one at the time, but it ended up being hurtful. And so you have to really review it from a peer review manner. Okay, that's why the whole peer review thing is like, I thought it was super cool. Like when I start going to conferences and see you guys, it's like you're not competitors. I mean, you actually want what's best for the patient, and you're having these open dialogues, and that's very cool because that gives me more confidence as a patient that something positive can happen from it. And so when we see that sort of thing happening, like Dr. Singhi, Eric Singhi, he does a social media thing. Okay, there's breast cancer doctors that do them. Okay, but know who they are. And most importantly, and I meant to say this in the talk and I forgot. Most importantly, don't get all your water from one well. Okay, don't just join one lung cancer group. Don't just join one targeted therapy thing and think they have all the answers. Get more than one piece of information because you really don't know what's out there until you kind of like have like the conversation.
Thank you. Dr. Baig, do you have any questions?
Yeah, maybe on advice for doctors, in terms of I've evolved in terms of how to communicate to my patients about how well something works, what the side effects are in a concise way. What's most helpful in your opinion in terms of how we should be presenting that information?
Wow, it's really tough to manage our expectations as patients. It's really tough. And as a patient, it's really hard for me to articulate what my problem is, especially you give me some stupid scale of 1 to 10, right? And it's like, what does my quality of life look like? How hard it is to dress myself? And it's like, well, I don't know. I didn't think about it, right? I just got through it. Okay. And so that's kind of difficult. So how can you manage it? I think in some ways you really need to be very upfront. Okay, whether you're talking about skin problems, mouth problems, we all think our hair is going to fall out. Okay, because it looks really glamorous, or I should say dramatic, not glamorous, dramatic on television. Okay, and so that's kind of what we envision as a cancer patient. So we don't know anything else until you tell us. And for folks that I've seen this, again, through the 9 years, I've seen this where people that are put on these targeted therapies, okay, you start getting just, oh, it's okay, I just take this pill and I'm fine, I'm fine, I'm fine. You have to stay vigilant about watching and staying scanned and being intentional about it and looking for what's next steps and have that confidence in your doctor, which is where the experts come in. So just kind of like try and manage it, okay? And until you have diarrhea and you can't pick your kid up, because carpool line is going to have you out of the house for 45 minutes, you really don't know how hard it is, right? And you don't recognize that. And that's where that whole friendships and those communities come in, right? And like I said, it's whether it's your neighbors or your faith or who people live in your same apartment building or what have you. Okay, don't be afraid to ask. Everybody wants to be the person that helps. Nobody wants to be the one who needs the help, but they don't know what you need unless you ask.
Perfect. Thank you. All right, that was wonderful. Okay, so I have exactly 6 minutes to answer some scientific questions. So I'm gonna go put it back to Dr. Herman and Dr. Bake. And I think one question, we discussed it in the first session, but I think let's repeat it again. And I'll put it to Dr. Herman. Should my family be tested? Now I have a mutation, let's say KRAS mutation. Should my family be tested for the same mutation? And if you can just highlight, when would you recommend molecular genetic testing for our patients?
Yes. So most often, these mutations that we're looking at are what we call somatic mutations, and they're mutations in the tumor cells. They're not mutations that are in your own personal genome or mutations that we're worried about being passed to family members. There are certain times when certain mutations may show up. They might not be the mutations that we are looking for specifically to target with drugs for the lung cancer. They might be other mutations that show up. They may be what we call passenger mutations or co-mutations or other mutations that show up that sometimes are more common to show up as germline mutations or mutations that are in the cells that you would pass on to family members. For example, the BRCA gene, we might see, which you may have heard about in friends, family members, or others who have had breast cancer. Sometimes that gene is more commonly seen as a germline mutation or a mutation that's passed on. So sometimes we'll see a gene that raises concern for potentially being a germline mutation, and that in those cases we would recommend doing additional additional genetic testing with a genetic counselor. There are also sometimes there's a frequency with which we see a mutation in the genome that would suggest potentially this could be a gene that is mutated in germline mutated as well. If we're seeing like almost 100% of the cells that we're looking at have this mutation, we might question it. Other times, strange combinations of genes that just indicate to us that maybe there is an underlying germline mutation that would need to be you would need to be screened. So I think it's always a good idea, just ask your doctor, say, is there anything on this panel that suggests to you that a family member would need to be tested? But in most of the cases, majority of these genes that we're looking at are not genes that you're passing on to family members.
Thank you so much. A question I would like to ask Dr. Bake. We actually haven't touched upon it at all through today. under what circumstances would you re-challenge patient with a targeted therapy?
No, I think this is something that a lot of oncologists do without a lot of knowledge in terms of how well it works. I think there is some data showing that in some patients, when we give the same drug again, it can, work, but for a limited period of time, they can. So the few times that I have done that are usually for patients who are on a targeted therapy and then went on to a different treatment altogether. For example, chemotherapy, antibody drug conjugates, something that wasn't constantly blocking that particular gene, because that suggests to me that perhaps the tumor is now back to being more dependent on that particular mutation after some time being off of a targeted therapy. So that at that point in time, then I would re-challenge, use the same drug again, sometimes as a bridge treatment to something else, but those are the settings where I would consider that. So have worked well in the beginning, patients have gone to other types of treatments in the meantime, and then perhaps come back to it.
Thank you. The next question, we have like 2 minutes left, but very important question. I'll ask Dr. Herman. Do ALK, ROS, and RET inhibitors have CNS activity? And yeah, basically, do those drugs have CNS activity?
Many of them do, and as we advance in our understanding of these drugs, and you may hear your doctor talking about different generations of drugs. This is a first generation drug, second generation drug, third. The higher generation drugs are, we're finding, these are drugs that have more efficacy in the brain. Again, these are systemic therapies. So when we treat you with these systemic treatments in the body, our hope is that we're treating cancer cells everywhere in the body, including in the brain. Some drugs have a better efficacy at crossing the barrier, the blood-brain barrier. The brain is a very protected organ. So we look for drugs that have better efficacy in the brain, particularly if you have baseline brain metastases when you're diagnosed, or even the idea of preventing spread to the brain. So the later generation drugs, for example, the later generations of ALK inhibitors like lorlatinib have very good efficacy in the brain. And so we're working on understanding the best ways to treat patients who have brain metastases and the best ways of preventing the progression to the brain. And yes, there are drugs within all three of those categories that do have efficacy in the brain.
Thank you. The next question I'm going to ask the Baig, and that will be the last question of the session. I'm going to read the question, but I'm going to have you rephrase it and highlight one part of the question. When the current targeted therapies stop working, and they specifically ask for the ALK, ROS, and RET, but it doesn't really matter. Are there clinical trials if the drug stops working? And maybe you can highlight the role of clinical trials that play in treatments of our patients with lung cancer.
And I think this is applicable to any subtype, not just ALK, ROS1, RET, in that there is explosion of clinical trials in the different subtypes. So I think the important piece to remember is that every time a treatment doesn't work, that would be, or even before then, that would be an opportunity to really look at what are the newer treatments that are in development that are looking promising, what's available in your state nearby, and really explore that at every juncture. And often the clinical trials are what's applicable to you does depend on the molecular sort of finding after each progression, because the genetics or molecular sort of underpinnings can change after each progression. So getting repeat molecular testing, knowing what's going on, and then looking for clinical trials at those transitions, I think that's very important.
Fully agree. We cannot, with Dr. Patil was discussing like where we are with lung cancer nowadays, we wouldn't be here if we did not enroll patients in the clinical trials. And unless we do so, we can stay where we are, which is not ideal for any of us. So definitely, you said it wonderfully. So I am going to put my time police hat back on. We have 3 minutes left in this webinar. Again, I'd like to thank my speakers, thank very importantly the organizers for this event. Thanks Grace for producing those events that benefit our patients. Again, would like to thank our sponsors again, the Genentech, Bristol Myers Squibb, Lilly, Takeda, Janssen, Daiichi Sankyo, Foundation Medicine, and Bayer. It is very important for the audience. Please, please, please fill out our Grace event feedback form. We would like to keep doing those webinars, and we definitely would like to see if there is anything we can do better. The link will be emailed to you after the event, and also every single presentation will be available for you to be viewed as a recorded content. We just need to edit it a little bit, and then it will be posted on Grace website again, as well as YouTube channel. Again, I'd like to thank everybody for being here today, and thank Grace for allowing me to chair this event and putting this event together.